Assalamu alaikum. Thank you, Dr. Wafa, for this nice introduction. I would like to welcome all of you to the fourth MEARC, Middle East Pediatric Allergy and Respiratory Conference. This is the fourth year we are doing this conference, and we are proud to say that this is the only specialized conference in UAE dealing with pediatric allergy and respiratory problems. We can see that every year the numbers of people interested in allergy and respiratory disorders are increasing. As you know, allergy is on rise, and we need to increase awareness of these disorders. So we hope that this conference will bring the awareness to the doctors and maybe to the community too, to the patients, and try to highlight about the most important aspects in the field of allergy and respiratory disorders, so you can take the latest evidence base to your clinics and apply it. As you know, it's a COVID time. It's a hard time for everyone. This is why we decided to do the conference on both hybrid, virtual, and personal on site. I would like to thank everyone who came and took the chance and the risk to came in this difficult time. But also we need to start our normal life back, and we need to encourage such meetings where we can meet and discuss and try to learn from each other on the latest evidence-based medicine in different topics. I don't want to delay you further. I think we'll start the first session. Dr. Wafa and Dr. Monica will chair the session and introduce the first speakers. Thank you very much.
Hello. Yeah. Thank you, Dr. Basu, for giving this opportunity. And as you said, we have to go back to normal, but keeping the precautions. So it's good that we started hybrid. And really, it's a very unique conference, and I feel really happy to be part of it. So we will be starting our first session with Dr. David, who is a qualified physician for allergy, and he did his allergy MSc in Stanford. And he was in American Hospital and he's now in Parkview. And he has a big, long experience on managing the children with allergy. And I think it will be very good to hear from you. How would we interpret the diagnostic test? Because we have so many and we get confused. I hope from the lecture, we will be getting a more simplified answer. Thank you.
Thank you very much. And thank you for the conference. Thank you, Basil. And it's a great job to see you all so this year after a funny year. And Yeah, let's start the conference. So what I want to talk about today, so I see allergy patients in Dubai, and I see patients, often they've come with allergy tests. So, and it's all about interpreting those. So I'm going to just do some cases, really, cases that you might see in your clinic. I'm going to, if anyone would like to participate, that would be great. But let's think about your practice and how we can perhaps help you regarding using allergy tests appropriately and their interpretation. So let's do the first question. So a 7-month-old girl, she's given scrambled egg for the first time. So that's fine. And we now say, of course, we want to start food before 1 year. We're not regarding allergenic food, we're not delaying food now. That's the current advice. And we'll have speakers talking about that later. But very quickly, within 10 minutes, she developed a rash on her face and some swelling, and she vomited. She was brought to the ER. Parents, of course, get very worried from allergic reactions or sudden changes. And she was given antihistamine, it got better. The next day, there was no rash. So the question is, what's the diagnosis? What do we think is going on here? So egg allergy, yes. So this is a straightforward case, I think, because it ticks all the boxes for an allergic reaction. So what are those boxes? So this is, I think, it sounds like IgE mediated. And there are 2 types of allergy, IgE and non-IgE. Dr. Basil will talk about non-IgE, but IgE is the one where we have a test for. So why do we think it's that? Well, the symptoms appeared quickly. So when you eat the food and you react to it, it's going to be within the hour. There's no delay to when the rash and the reaction starts. The classic symptoms are rash, which is itching, swelling and vomiting. And of course, more severe symptoms may include breathing difficulty, but not in this case. There's no previous history of ingestion. So it's not like this child had egg before and seemed to be tolerating it. It's the first time. Now, the child must have been exposed to it, but we know that babies before 6 months may be exposed to food proteins through the skin. So, but it's the first time eating it. And there was prompt recovery. But we should do a test just to make sure, to corroborate that history. But certainly the history is very, very suggestive. Now, what test would you do? That's the question. You need to do it, yes. Well, okay, the history, okay, so we have a clear history, very suggestive, but studies have shown that parents can get the story wrong. So for example, it could be a coincidence, you know, now unlikely, but we should get the confirmation. But diagnosis is 90% history, but we should do a test. Now the question is what test? And this is one of the problems we have, because many doctors are ordering this test, which is the food panel. And this is what happens when you do the food panel. So let's look at here. So if we see here, so egg is high, okay? So the egg IgE is high. The child has a history of reacting to egg. We have our answer. We have diagnosed egg allergy. But when you do a food panel, other things are coming up. We see we've got milk a little bit high, wheat, soybean, peanut, hazelnut, walnut, lentil, all these other foods, but we were not looking at those foods. And obviously we can check the history, whether there was any of these foods this child eaten, probably not, but we are looking at egg, and egg is positive. But somebody reading this test will think the other foods are positive too, and will wonder what they do about it. And in fact, and the problem with the food panel in this scenario is that the mum can be sometimes told to avoid all these foods as well. But for example, this mum, in this scenario, the mum says, but I was eating yogurt before. Why am I being asked to avoid dairy? And the point is, from allergy tests for food, is that having IgE does not mean you are allergic. Allergy is defined as having a reaction to something. So parents will say, oh, my child is allergic to this, this, and this. And I ask them, why? What happened when they ate it? Oh, no, they've not eaten it. They had a test. Well, they may be allergic, but they may not be. And we can't rely on the test. A positive test only means that they are sensitized, which means they have IgE. But it does not, but but it's not telling us that there are going to be symptoms on exposure. So for this case, if you do a food panel and you pick up other things, it's going to get complicated. And you know, the research is there. This is a study in the US looking at over nearly 800 patients who had a food allergy panel in an allergy clinic. And in fact, and over 120 individuals were avoiding a food based on the recommendations, but 90% of them were told to bring that food back when they were seen by an allergy specialist. And in fact, the positive predictive value, therefore, in this study, showing of 2.2%, which is extremely low. And there's various studies looking at blood tests and then challenging them. And you know, we know that lots of children are sensitized, but it doesn't mean they're allergic. So this study here, that 16% of the group had IgE to the nut, to egg, but when they were challenged, only 9% reacted. Peanut, 9%, 3%, etc. But obviously, what we don't want to do is overdiagnose. So the question really is, when we think about when we should do an allergy test to food, the key thing is the history. Find out what the history is from the parent. What's actually happened? What are they worried about? So sometimes parents come, I'm worried about my child's got food allergy. Okay, why are you saying that? We can't just do a test. We need to know why. Let me know. And if there's a food that's suggestive, then we test that food. But we should only test the foods that the parents are reporting as being allergic, potentially allergic, and fitting with the story. The story being, when they eat the food, they have a rash, swelling within the hour, rash goes away next day, happens every time. So certainly I would do a blood test for egg here, or a skin prick test if you have that. And then if it's positive, but also parents like a blood test as well, or a test, because they like to see a test. They want a test, which is fine, but just doing the right test. But the problem is, if we screen and start delaying other foods which they're not allergic to, that is going to lead to more allergies. So this food panel said peanut was high. 7-month-old child's not eating peanut. Does that matter? Well, it does. So there's a study which you may know about, the LEAP study, which will probably come up during the conference. And this was a study looking at children who were randomized to either be given peanut before 1 year or avoid peanut for the first 5 years. And then the instance of peanut allergy was looked at that point, and then they were followed on for another 1 year when they both avoided peanut. And was there any difference? And that early introduction had a massive difference in their risk of developing peanut allergy. So here on the left, 60 months of age, the incidence of peanut allergy, 19% in the group that were avoiding peanut for the first 5 years, 3.6% in the group that were given peanut in the early stage. So if we're potentially avoiding foods based on panel testing, we are risking increased allergy with them. Now, these children in the study had egg allergy or severe eczema, so they weren't the normal population, but they're the high-risk group. It really highlights beautifully how it's important to not delay introduction of these foods, which may happen with panel testing. Because as I said here, the peanut was 0.76, not very high at all, but positive. It comes up positive on the panel. And the child was also told to avoid dairy because it was a bit high. And maybe we say avoid dairy because this child was getting some coughs and colds. And I do see patients who are told to avoid dairy due to coughs and colds, but there is no evidence to support milk causing mucus. Zero evidence. And the problem is, if you're avoiding dairy, there's a knock-on effect there. Now, if obviously sometimes what happens is the parents avoid the dairy, the child gets better. But of course, if the child had a virus, they will get better. So in that situation, at the very least, we should be bringing it back to C. But if you avoid dairy, there is a problem for that child's growth, bone growth, and development. And this study here, so the bone mineral density in young adults who had milk allergies. So of course, some people need to avoid milk because if they are allergic, and the calcium intake was reduced, and it led to lower bone mineral density in those adult children who had milk allergy compared to those that didn't. Likewise here, osteopenia, the risk in adults who had a diagnosis of milk allergy when they were younger was much higher, but if they brought the milk back into their diet, it was reversed, it got better. So it's really important we don't overdiagnose milk allergy. And the impact of food allergy diagnosis is huge. It's a lot longer to shop, much more expensive. Parents are looking at the ingredients, they're worried about what's happening nearby, etc. This has been studied extensively. Quality of life scores are much worse than having type 1 diabetes, risk of compromised nutrition, long-term impact on feeding behaviors, but an increase of risk of developing new allergies if they are avoiding foods wrongly. Now, what about egg in a different way? So this Christian is a 9-month-old that's been had egg 3 times, and each time has had a rash on the face. But mum reports that when the child was eating it, she seemed happy. The child didn't seem distressed. So when children are having an allergic reaction to food, so older children, they may say to you, they've got an itchy mouth, etc. They're not happy. Young children, infants can't, but you still notice that they're not happy. They reject it. But this child was eating it fine, had a bit of rash, but it disappeared after 15 minutes. Mum says no other foods cause a rash. So the question, what's the diagnosis here? Is this egg allergy? Well, this story is very different, isn't it? Because first of all, the reaction is mild, just a bit of rash on the face. The child has eaten this several times, seems to be okay. There's no swelling and the child is happy. So this may not be egg allergy, but as a pediatrician, I certainly would expect you to be thinking about it and perhaps not be happy to say no, of course. So I would do a test here. And the test was slightly high. So that previous child was very high. Now it's still slightly positive, but then we go back to the history, and the history suggesting not quite classical reaction like before, and the child enjoying it. So what I would do here is try this child again. So we see lots of children who get rashes on the face from foods because of the juice and the contact. And if it's just the rash where the contact of the food is becoming contact, then it might not be allergy. Allergic reaction rash is coming from the inside, so it should be all over or spreading potentially or vomiting, etc. So here I would challenge again, or at least if you're not happy to seek advice on that. But the fact that this child is having these mild reactions, potentially, if we just said avoid egg, this child may go on to develop egg allergy for real. So really important to pick these out. And we do have certain levels in the blood test, which if they are above that level, then we have a high predictive value that this child is allergic and not just sensitized. But the levels are different for different foods. But really, when it comes to diagnosing food allergy, we do a test and we take the history. So if the history is good and the test is high, allergy is diagnosed. So we do need to look at both things. If the history is intermediate, mum's not sure what was eaten, and the blood test was intermediate, not too high, is it possible? Now, I think as a pediatrician, really what I'm saying is we can't rely on the test. And if there's take a good history, and if there's any doubt, then do maybe contact your local allergy specialist just to find out a bit more, maybe do a challenge, because as I said, we don't want to overdiagnose. And the prevalence of food allergy, this is in the US from last year. So, overall convincing allergy is 10%, but when it's been diagnosed by a physician, it's 5%. So there are those patients who are believing they have allergy, etc., out there that maybe they don't. And we need to try and unpick that. Now, what about siblings? So this one, 2-year-old child with a 9-year-old brother who's got peanut anaphylaxis. So mum is worried about her child having peanut allergies. She's seen the oldest brother have peanut anaphylaxis. So she's now avoiding all nuts in this child. And what would you do? How would you manage this? So would you do a test? But again, how useful is a test? Because we said a test doesn't tell you are allergic or not, But if this child has a brother with peanut anaphylaxis, it's actually quite useful to know about this 2-year-old and get the food in there, because if we delay it, like we've shown in the LEAP study, and leave it too long, the risk of that child also developing peanut allergy goes up. Yeah, so that's the thing, yeah. So there's a study looking at sibling food allergy, over 1,000 children. 33% of those had a negative test and no symptoms, but over 50% had a positive test and no symptoms when they were given the peanut. And 13% had a positive test and also allergy. So there's a high risk of, sensitization and overdiagnosing of allergy. So, I mean, the best thing here would be to give peanut, absolutely. And how does a parent feel about that? And if they're worried, do it in hospital. I mean, I say to, look, you could sit in the car park, in the ER, do something. Let's find out whether this child is or not, and then introduce it, because we are trying to prevent new allergy in children. Now, eczema. So common problem. So 11-month-old with eczema. He's scratching, he's bleeding, he's got red areas bleeding, suffering. So he's poorly controlled. Mum says she puts on all the creams regularly. Never believe that. Or at least if you believe it, or at least make some more inquiries about that rather than just taking that as true. Mum's uses steroids, but at 5 days, she's afraid to go further because doctors have told her you must stop at 5 days. But honestly, I want to be that doctor, because I want the same crystal ball. How does that doctor know 5 days is all that's needed when you're in the clinic? You don't know that. And Mum is convinced it's food allergy and wants a test. Common scenario. With eczema, they want a food allergy test, and the parents think, oh, if I know what the food is, the eczema will go away. Not true. And this is what we're talking about. And look, the bleeding, red, unhappy child. And of course, if the child's scratching at night, they're waking up, family are waking up, parents get divorced over this. This can be very challenging. But the key thing here is eczema is a skin problem. It's not a food allergy problem. So when someone said, I want an allergy test, why do allergy test? Why? It's not a food allergy problem. It's a skin problem. This is what we need to explain to parents. And it's a filaggrin problem. Filaggrin is a protein in the skin, and gene mutations lead to damaged skin barrier, dryness, scratching, inflammation, and it's all about, and the severity of the eczema is dependent on the filaggrin gene expression. So eczema is a skin problem, but that lack of barrier does lead on to food allergy, etc., because the proteins can penetrate the skin, but the treatment is not avoiding the food. The treatment is sorting the skin out. So, this is what I say in clinic. I say to parents, look, eczema is a skin problem. It's not an allergy. And I find out how are they treating the eczema? What are they doing? Moisturizers, 3-4 times a day, steroids. What are they doing? How are they doing it properly? I explain allergy tests don't help, because allergy tests, you would do a food panel, you would get all these foods being a bit positive, and it doesn't mean they are allergic. Unless they come and say that my child has reacted to a food, that's different. If they come with a history like that, then that's fine. But often they don't. An allergy test will not reveal something that if they avoid, they suddenly don't need steroids. There's lots of steroid phobia out there. Lots of things make the eczema worse, things in the environment, etc. And really, I would only do allergy tests if there's a history of immediate reaction, then definitely I would test that food. Or if the eczema is really, really badly controlled, and they are doing their treatments, then we're sort of scrabbling. But very few get to that stage. And so this, and this is what happens. You do an allergy test for eczema. So comprehensive food allergy profile sounds so good. But it's, and they've tested lots of foods, but a little bit positive nut mix. I mean, nut mix, please don't do nut mix, because it's positive, but you don't know which nut's positive. It's just telling you it's not helpful. And then egg, like 1.38, okay, a bit high, but is that causing the eczema? So look, I mean, if the food is causing the eczema, then fine. If the parents are noticing an issue with food, if they think the eczema is triggered by a certain food in the diet, then you can avoid that food. But based on the history, not the blood test, you avoid it, review the child, they say it gets better. Okay, fine, but then bring it back, because it may be better because they're using the creams, etc. Because again, we don't want to limit these foods unnecessarily. It causes anxiety, it causes feeding behaviors. And if we avoid egg when they don't need to, we are risking them developing egg allergy for real. And food sensitization is much higher in eczema than the normal population, but as is allergy too. But sensitization, so often with eczema, you'll get very positives in food panels, and it just causes a lot of anxiety, and then it gets very complicated, when really it's all about treating the skin. So skin barrier, we need to use the moisturizer. What are they doing? They're often only doing it once a day, etc. No, 4 or 5 times a day. Steroids, what are they doing? Oh, only when it's really bad, and maybe for a few days. No, you use it until it gets better. It's very safe. The risk of thinning when you use it properly is almost zero. And actually, when we're thinking about preventing food allergy, this nice study here looked at when children were started on their treatment. So if there were delays to their treatment for the eczema, which meant for a longer period their eczema was poorly controlled, their risk of developing food allergy was much higher. So actually, if we want to prevent food allergy with eczema, early intervention, get the basics of treatment in there from an early age. Doctor, my child has watery stools. Doctor, my child has behavior problems. Doctor, my child gets headaches with certain foods. Doctor, I want an intolerance test. Basil, will you do it? Man, it's $3,000. No, don't do it, please. Please don't do it. This is what you get. All these foods in the avoid, and of course, it's always the same foods. It's always these foods because they're eating those foods in their diet a lot. The body's exposed to those proteins a lot. The body makes IgG a lot because they're exposed to those proteins a lot. And making IgG is normal. And it doesn't correlate to being intolerant. Now, they may be intolerant to some of these foods that are coming up, but it's not by the test you do that. It's by doing a history, parents doing a food diary, they suspect a food, they think some association, avoid that food, things get better, bring the food back, it gets worse. You need to bring it back to see it getting worse and do one food at a time. But often when I'm seeing patients like this, they are better, great, let's start bringing the foods back. But it's very clear that IgG testing is highly inaccurate, and there's no evidence, and all the allergy bodies, American, European, British, everyone is saying very clearly IgG testing should be avoided. But parents want answers, don't they? I know it's hard, they want this test, and we have to feel confident in saying to them, look, it's not going to work. But with intolerance, they can do a diary or something like that. Now, question 6, 5-year-old child, cough and cold, had peanut for the first time in the early evening, and he woke up next day with a rash, and it's been on and off for 3 days. Dr. Ahmed, what do you think? What about the peanut though? No, it's too long. It's too long. The rash appeared the next day. If that child reacted, they would have known about it. And of course, urticarial rash, so this is the rash child had, is not always allergy. It's often not the allergy in children. So again, back to the history, what happened before the child had a virus, what the eating was many hours beforehand. So I wouldn't do any allergy testing here. This is the first time it's happened. It's been going on for 3 days. If it was allergic, whatever they were exposed to has gone away now, yet the rash is still there and likely to be carrying on. So this is acute urticaria. Allergy testing is not helpful with a story like that, at least. But no previous history. Recurrent 3-year-old, recurrent coughs and colds for 6 months. Is in nursery. Doctors think this child's got an allergy. Mum says, when I give Zyrtec, it gets better and it goes away up to weeks. Is this allergy? But I see a lot of children who are worried about allergy because we're not sure what's going on. But of course, lots of children get coughs and colds, and the child's in nursery. One of the questions I'm asking this year is how was the child last year during lockdown? Because if it's allergy, they should still be having problems. They were in the house all the time. But if they say, oh no, last year he was really, you know, this is exposure, coughs and colds, etc. So ask, you know, if you think about allergy, okay, coughs and colds, are they having symptoms in between? It should be itchy nose, runny nose in between, because if it's allergy, it's not so much up and down, there's a constant going on. Family history of allergy, there often may be something there, or the child has eczema or food allergy. Is there any asthma? And asthma is a breathing problem, it's not just a cough. And of course, if there's lots of fevers going on with these coughs and colds, then it won't be allergy because fever doesn't cause allergy. But it can be hard, maybe, and certainly now here, a panel test may be helpful. And likewise in asthma, you know, a 13-year-old asthmatic, he's got 3 courses of steroids, he's on Seretide, 2 puffs twice a day, which is a long-acting bronchodilator and a steroid. But mum's saying he needs Ventolin 2 or 3 times a week, and he's been to the ER in the last few months. And what about here? What about allergy here? You know, this child, his asthma is poorly controlled. He's needing lots of Ventolin, he's on lots of steroids. And in the UK, in the study looking at asthma deaths, he fits the high-risk category for asthma death. And yes, let's think about allergy, but before we think about allergy, much like when we talked about eczema, get the basics of treatment right. Are they taking their medicines? Are they using their inhalers right? Have they got an asthma plan? But do ask about the environment, any pets, any variation with pets, seasons, damp, etc. And I would do that, and I would definitely do an allergy test here, even if it's not clear, just to make sure, because this child's asthma is poorly controlled. And that child with coughs and colds, if the parents are worried about allergy, then you can do a test. And in children, allergic asthma accounts for 90% of children with asthma. There's allergy involved, but in adults it's less so. But in this study in the UK, have you ever been tested for allergies? No, 70%. It's not something we think about with asthma. But when they were tested, did it help your asthma? Yes, in 95%. So we talked about food panels in food, and I would avoid, but with things in the air, I wouldn't avoid. And obviously with things in the air, there's lots of possibilities. So we've got cat pets, molds, dust mite, grass, but of course, lots of other things trigger asthma as well. So it's not just allergy, but at least let's look for those. And of course, you know, indoor allergens, there's your dust mites where you can test for, there's pets, and there's mold. And of course, people spend most of their time indoors. If you think about it, vast majority of your time is spent indoors. So if their breathing is a problem, let's look for those possible allergens, and then we can do something about it, but we've got to find it first. And for dust mite, lastly, there's things you can do, but one of the key things is getting some covers for the mattress and the pillow that trap the poop, which is what they are allergic to from the dust mite inside. But there's washing the bedding and things like that. So, and obviously, you know, if we suspect that, so if we look for it and we find it, we can give parents some advice about how to manage it. So I do tests. I do a panel for respiratory. And then, you know, and here, if this is a child, now there's lots of things that are orange, okay? But if you overdiagnose pollen allergy, it's not a big problem. But if you overdiagnose peanut allergy, that is. And here, this child was having problems in the summertime. But look, the dust mite is negative. The pet's cat is negative. Dog's a little bit. Is it significant? Could be sensitization. But at least we can try compared to with food. So this is the panel I like, and I think this is a good thing to do. Hopefully you have access to this sort of test for things in the air, and it can make a big difference for a child's breathing problems, especially if they have asthma. And the negative test is helpful and fairly accurate in saying they are not allergic. So that child with coughs and colds, if it's all negative, at least we can say no allergy, stop the Zyrtec, etc. So I hope those cases were helpful, and they are similar cases to what you might see. So I think, look, I mean, allergy tests, you know, do them, but you just be careful if you're not sure how to interpret them. But certainly if you're going to send it on to your allergy specialist, then doing a test beforehand can be helpful. But at least if you just focus the testing to the food that the parents are reporting, it's much easier to interpret because then you have the story. But with eczema and asthma, allergy testing is not helpful. First of all, do make sure they are getting the basics of the treatment right. But you know, hopefully, as doctors, we can't know everything, you know, and I speak to doctors all the time for advice. I know my limitations, and I think it's important that we do seek advice when we're not sure. Okay, thank you very much.
Thank you very much. I think you made life of pediatricians bit easy, you know, with all the examples. So house is open for questions. We'll have some questions. You want to ask one?
Sorry for my voice. Thank you, Dr. Davis. It's amazing, actually. I have like plenty of short questions for you. Like, first of all, for example, in our hospital, we had milk as IgE only for milk, and then we have a panel. I want to search for egg alone, or could it be done or sorted to the lab? And we don't have, except for milk, the IgE specific blood test. So
yeah, I mean,
it's available at your place, like each one alone?
Yeah, it's available,
okay.
yeah.
So the other question about respiratory allergens, like many different trees, I don't know the names, weed. Today a patient, cows, I'm not the one who ordered, it was a dermatologist, and cows and cats and stuff. He had the rash and like urticaria all over the body. So only this, nothing, no swelling. That's a good reaction. In that case, what can I tell this patient?
So how long has the rash been going on for?
Like it happened the third time this time. Of course, the dermatologist asked for food allergy,
right,
which was also a full list. But I told them no, it completely, because we didn't have any reaction to food before.
Because the parents are bringing a story of food, and you know, only test what the story. So I mean, so things that so you did a panel in the air. You did the air allergen panel.
Yeah, they did the allergy panel for the several types of trees. Right, I can't remember.
Yeah.
Weed and cats and cows.
But so I guess so. What comes up? Then you're going back to the history. So you speak to the parents. Okay, is the child in contact with anything here?
Yes, they said about the trees and grass and all that. Whenever he plays outside, they have this.
Oh, okay. So you, because obviously any test you then match up with the story, and then then I guess I mean, look, I mean, you know.
So in that case, avoidance as
well, it may be hard, mightn't it? Yeah, exactly. So and if it's a mild reaction, a child needs to play. They could take antihistamine. So if they're going to an environment which they worry may cause a rash, they could take some antihistamine beforehand.
So it's going to be easy.
Yeah, maybe try.
Yeah, Dr.
You don't need a microphone.
Thank you, David. Dr. Omar Ahmed, American Hospital. Are you advocating that there is no relationship between food allergy and eczema and asthma?
So in eczema, so under 1 year, then there may be a relationship with milk. So if it starts very early. But children who are over 1 year of age, where the eczema started a little bit later, then it's not zero, but very unlikely. And my point is more about how to try and find out what the food is, if it is, when it's probably not. But if it is, panel testing is not helpful. It's the history. But parents come without doing the basics of treatment first necessarily. And they think, we'll do a test, we remove the food, and the skin will be all right. And the skin is not a food allergy problem. So we're not saying food has zero influence, but I think it has a lot less than we think. And it's about treating the skin. You know, all you can do for eczema is moisturize. Really, you know, and now if it's more severe, there's obviously steroids and all these things, but as a treatment for dry skin, let's moisturize, and you've got to get that right. And actually, those parents, they think there's a food. If they do the basics of treatment right and the eczema's better, then you know there's no food because the eczema's better, but you're still eating it.
There are certain foods that will make the eczema worse. So there are certain foods definitely that can make eczema worse.
So
not asthma, but eczema.
yeah, so under 1 year, the dairy, we talk about avoiding dairy, but okay, but if, and there may be, but then the way you diagnose it is not on the test. That's the point. You can't rely on the test. You have to avoid, it gets better, you bring it back, it gets worse. But the belief that food's a problem, so many allergy doctors in the US and UK won't do any allergy testing on food unless the parents come with a history of a reaction, you know?
Taking the same question, I think, because we see babies who are given like cow's milk from the beginning and they get that atopic and later eczema, and then we relate this to be milk allergy. So how can we say, when, according to you, it doesn't hold true?
No, so under 1, so the babies, I mean, it was just a brief, but so under 1, so if the child is introduced dairy and the eczema's got worse, then yes, so we go on the special formulas, things like that. But it's those older children, so the under 1, they were fine, and then, you know, mild, yeah, but those ones particularly.
Another question from your first case, where you showed that there was egg and then there was a urticaria. But so many times we get parents bringing a child where they are not really that specific that this particular food causes this urticaria, but yes, he eats something, and it causes urticaria. And when you do those panel of allergy tests and you get so many things plus, then what do you do? Because your history was very clear, but you don't get every time the same clear history.
Yeah. So, but that's so if parents don't give a history, but so the reactions are mild. They get a bit of rash, but they're eating it. They're not having any big reaction, but they will notice, you know. But if they have no history to give you, then it's very hard to diagnose it. And I would, you know, and if they are avoiding certain foods that they think, you could test those foods at least that they are avoiding, because, you know, because we want to know whether they can bring it back or not, you know. But if the history is vague, often I will challenge again in the clinic, you know, because a proper allergy is normally, but it can be difficult. I mean, you know, it can be difficult, but focus on the history as much as best as you can.
Thank you very much. It's a great, I think, very great, clear messages with regards to allergy testing. My question is about siblings with food allergies, especially nuts. And you come and you test a sibling and they're negative. What advice do you give them? Because commonly the house should be nut-free. That's one of the challenges I encounter a lot, and I really don't know how to deal with it.
Yeah, so I mean, the reality is, so parents worry about nuts being in the environment when the child has allergy nearby. But severe reactions to nuts happen if they eat it. You know, they don't happen if it's nearby. And there's been studies looking at peanut butter being open nearby, no reaction. So, but obviously they need to be careful regarding contamination, things like that.
The contamination, and you know, if it's a younger child, you find something on the floor, or especially if they had anaphylaxis or, you know, severe reactions.
So I guess they just need to be, you know, if the child's at school, give it certain times, try and plan for that, make them aware. But the benefit is crucial, isn't it? You know, because if they carry on avoiding nuts in that other child, we're trying to prevent allergy in the future, you know. So I would, you know, even if the test is negative, I would probably challenge in the clinic, because they'll probably still be worried to give. So the child's not there, right? We know it's not allergy, and then they need to think of some way, you know. But keep getting it in there. But
another question, like we have two types, like we do the skin allergy and it also goes and talks about IgE, and we do the blood test. So what do you recommend out of the two and why?
Well, I mean, it depends on what you have access to. So, I mean, you know, skin prick testing, me and Basil and a few people can do. You do it in the clinic. You have an answer. You get, you know, you can make a plan. But if you don't have skin prick testing, but then blood test is fine, you know. But it's more about the history. It's more about doing the right test at the right time, as opposed to which test is better than the other. You know? That's the key.
One more question. So I have known for a long time that from research and conferences that the severe eczema, I mean, is the only one that can be related to food allergy. So in that case, not even severe can be linked to food allergy.
I think it depends on the age. So if a child under 1 starting early, then there may be some, but the older the child gets, the likelihood of food playing a part goes down, especially if there's no history of any allergic reactions. You know, that's the thing.
And the child with the mild reaction, can you just let them go on, or it has to be done? I refer it to the expert.
No, I think, so the history, look at the history. If it seems mild, I guess it depends on the parent. The key thing is we don't want if the parent's scared to carry on, and then by avoiding risking developing allergy, may need the expert. You know, but if the parent's still happy to give, then that's, yeah. But you could try in the clinic maybe or something. Yeah. It's just finding the expert. Dr. Basil.
Yes, thank you. Tomorrow we have a full talk about food allergy and eczema. So I encourage everyone to listen to that.
I think we'll end this session. Thank you very much for a very, very interactive session and giving us
So I'm lucky that Dr. Basil. So our coming talk will be by Dr. Basil. Yes, consultant pediatrician, allergy and respiratory at the American Hospital, Dubai, UAE. Dr. Nasrallah has other qualifications, the American Board of Pediatrics from the US and the MRCH with certificate of completion of training from the UK. He did his basic medical training from Jordan University of Science and Technology. He finished his pediatric residency training from Texas Technology University, USA. He was appointed as the chief of pediatric residents at Texas Tech University for 1 year. Dr. Nasrallah moved to the UK to pursue further training in pediatric allergy and respiratory diseases. He worked as the specialist registrar at the pediatric allergy and respiratory department in the Great North Children's Hospital, Newcastle. Dr. Nasrallah recently had his postgraduate certificate in allergy and asthma from Imperial College, London, UK. He is an active member of the British Society for Allergy and Clinical Immunology. Dr. Nasrallah has been working as a consultant physician and immunologist in the UK at the University Hospital of South Manchester.
Thank you very much. I don't know who gave you this CV of mine. I think that the talk's supposed to be to Dr. Nutritionist Iceland, but she apologized in the last minute, so I jumped in just to talk about cow's milk allergy. Okay. So today I'm going to talk about the global rise in allergy, cow's milk allergy types and diagnosis, elimination diet with cow's milk allergy, cow's milk allergy management, and conclusion remarks. So as you all know that allergy is on rise, and 30 to 40% is the prevalence of allergy worldwide, 5 to 8% in infants and young children. And the most common food allergy is the cow's milk, which is about 2 to 5%. And the most common food that causes anaphylaxis in children is cow's milk. After that comes egg and the nuts, cashew, hazelnut, and peanut. The prevalence of allergic diseases in the UAE also are high. As you can see in the UAE combined, it reached up to 32%, in Lebanon 45%. So we have high allergy prevalence in the Middle East. And the burden of allergy is not just about symptoms, it's also there is a physical burden, there's a psychological burden, there's a financial burden, and there's a social burden where the child is feared and isolated due to his allergies. So what is the definition of allergy? It's a reproducible adverse reaction to one or more milk proteins, usually the casein or the whey, beta-lactoglobulin, mediated by one or more immune mechanism. The immune reaction may be IgE mediated, non-IgE mediated, or mixed. And the cow's milk protein is the leading cause of food allergy in infants and young children less than 3 years. There's a big difference between milk allergy and lactose intolerance. In lactose intolerance, you have no immunological reaction. It is just an adverse reaction to food where you cannot tolerate the lactose because you have a problem with digesting the sugar. So cow's milk allergy prevalence, if you look, it's mentioned, it's a range between 1.8 to 7.5% of infants in the first year of life. But there is an overestimation of that prevalence, and only about 1 in 3 children presenting with symptoms of cow's milk allergy is really confirmed to have cow's milk allergy. And there is a well-known study called the Europreval birth force study, where they looked at 12,000 children recruited and followed until 2 years of age in whole Europe. And they looked at the prevalence of milk allergy, and they found that there is the range of reported of food allergy, it's self-reported, is overestimated when you clinically prove it by a physician. So the highest risk was in the UK, and it was only 1% instead of 2 to 5%. And the lowest was in Lithuania and Germany and Greece, which was less than 0.3%. So as you can see from this study that yes, we have milk allergy, and we keep mentioning and saying that it's the most common food allergy and it's a common problem, but not every child who's having milk allergy really has milk allergy. It's a self-reported problem. You have to be confirmed by a physician. And if you really confirm or challenge, then you will discover that only 1/3 of these babies have milk allergy. A 9-month-old, totally breastfed, first introduction of cow's milk formula, 1 minute after the first feed, the child started to develop rash, eye swelling, breathing difficulty, and was rushed to the ER. She was given antihistamine and IM adrenaline, and the reaction resolved, and this is how the child goes. So what do you think, what type of milk allergy is that? It's the IgE-mediated milk allergy. And the IgE-mediated is easy to diagnose because it's an immediate reaction. From the history, you can tell that there is a high suspicion that there's a milk allergy. It happens immediately within a few minutes, maximum to 1 hour of ingesting the milk. You can do skin prick test or IgE-specific test for milk proteins, and then you can confirm the diagnosis. And the treatment is simple. It's allergy action plan with the parents. They need to avoid the milk, which the child is allergic to, continue breastfeeding, and consider extensive hydrolyzed formula versus amino acid formula if the mother doesn't want to breastfeed. And you can retest again in 6 to 12 months by doing the skin test or specific IgE test, and then advise the parents about the challenge. So simple, easy, quick, IgE, milk allergy. What about the other types of milk allergy, which is the non-IgE, which is the delayed reaction? It is more challenging. It's not easy to diagnose. The reaction is delayed. It usually occurs after 2 or more hours of consuming the cow's milk or the dairy product. And symptoms may include eczema or delayed vomiting. And allergy tests are usually negative and they are not reliable. So there is no reliable test for non-IgE mediated cow's milk allergy. And the mechanism sometimes is not known. There is a T-cell involvement, it's late onset, and the main symptoms related to the GI, skin, and the airway. So if I would ask this question, cow's milk allergy in infancy mostly present as IgE-mediated cow's milk, non-IgE-mediated, mixed presentation, or depends on the country. What do you think? be non-IgE mediated cow's milk. Do you all agree? Okay, I mean, I was thinking the same. Based on the study I just mentioned before, the Euro Preval study, they looked into the prevalence of cow's milk allergy, which type, is it IgE or non-IgE? And as you can see from this study, that the cow's milk allergy is in the gray, the IgE-mediated cow's milk allergy in the black. And you can see, for example, in the UK, the type of cow's milk allergy, it's mixed, and nearly equal, IgE and IgE. While if you look at other country, Lithuania, for example, you can see that most of the cow's milk allergy based on this study is IgE mediated. So if you look at the total, you will see that IgE mediated is more common than non-IgE mediated, which is a bit surprising, but it's true. But also depend on which country you are living. So some countries they have mixed, some countries they have more prevalence of one to another. In the UAE, we don't have study to know exactly which is more common. Reem is a 3.5-month-old baby who presented with arching back, persistent crying, pushing the feet, colic, weight flattering. Breastfed baby, but now mother started formula for the last month. Mom tried simethicone drops for colicky babies, not improving. She has a bit of reflux, diagnosed to have reflux esophagitis, started on domperidone and ranitidine, but the problem is not solved and the child is in pain. So here you start to think about the non-IgE mediated cow's milk allergy, which is a bit hard to diagnose in some babies. And the symptoms of non-IgE cow's milk allergy can start not immediately, but can start from 3 days in 28% of the children, 7 days in 41. It can, after 1 month, 68% of the kids, they have the symptoms, and after 1 year, nearly all the kids have the symptoms. But what are the symptoms of non-IgE cow's milk allergy? It can be a combination of GI symptoms, which is the most common presenting symptoms, like diarrhea, constipation, vomiting, reflux. Can be skin presentation, like eczema, urticaria, rashes, and can be respiratory, which is rare, but they can present also with cough, wheeze, and distress. And they can present with other symptoms where the child is unsettled, cranky, and refusing to eat, with flattering of growth. So there is a big challenge in diagnosis non-IgE mediated cow's milk allergy, and there is no single reliable test available, and there is always delayed in symptoms onset, and manifestations are diverse, can be mild to severe. There's overlap with other diseases, so that makes the diagnosis even more and more difficult. And there's a significant impact on the life of the child and the family. Delayed in diagnosis prolongs the stress for infants and their parents. So the average time to make diagnosis on many studies is 4 months of age. And sometimes in some studies, they need more than 18 health care visits to reach to that diagnosis. And we think it's just a simple, and alhamdulillah, here in UAE, we are getting more and more aware of cow's milk allergies, but in some places, this is still not diagnosed, and it takes several visits to the doctors to reach that diagnosis. So an earlier diagnosis reduces treatment length and cost of management. What are the guidelines available for treating non-IgE cow's milk allergies? There are a few guidelines available, and the most famous ones are the SPGAN, the BASAKI, the IMAP, even the Middle East, and Dr. Mighdadi here is involved in these guidelines, Middle East statement on the prevention, diagnosis, and management of cow's milk allergy. So if I take an example for these guidelines, one of the common guidelines and famous ones used is the IMAP, milk allergy for primary care physicians. And if you look at these guidelines, just it will guide you how to diagnose and manage non-IgE cow's milk allergy. So they divided the diagnosis and management into two arms, the exclusive breastfed baby and the formula-fed baby. So if the mother is exclusively breastfed and we suspect high suspicion of milk allergy on IgE, then we have to do the elimination diet and see, but not to forget we have to reintroduce the milk to confirm the diagnosis. If it is in the formula-fed or mixed-fed, then we have to move to the elimination diet and thinking about formulas and then do the reintroduction. So in the absence of reliable objective diagnostic tools, clinical assessment is with cow's milk protein elimination and challenge remains the fundamental for the accurate diagnosis of cow's milk. So we have to remember that testing is not available in such cases. So if you decided to, if the baby is not breastfed or mixed-fed and you want to go for a formula, and you have to choose a formula for a child with mild to moderate cow's milk allergy, which formula you go for? Number one, soy formula. Any other suggestions? Number B, extensive hydrolyzed formula. Who's with C? Okay. B, okay. I would go with B too. The main reason is because it's a mild moderate, it's not a severe. We'll talk more about when to go into the amino acid formula. So yes, according to the international guidelines, yes, the extensive hydrolyzed formula is to be recommended for the initial prescribed formula for most infants presenting with suspected mild to moderate cow's milk allergy. So you can go for amino acid formula. It also works, but usually for cost effectiveness and the taste, you may choose to start with the extensive hydrolyzed, especially for mild to moderate cow's milk allergy. And the SPGN also recommend that for breastfed infant, strict cow's milk protein diet is recommended. For bottle-fed infant, extensive hydrolyzed milk protein. The same for the American Academy and other Basaki and other allergy bodies. And the efficacy and safety of hydrolyzed formula for cow's milk allergy has been studied and systematically reviewed in different randomized controlled trials, and the conclusion that extensive hydrolyzed milk products are safe, well tolerated by most children with cow's milk allergy. So this is the common slide. We see it in most of presentation about different kind of formulas. We have the intact protein formula, the normal formula, the partial hydrolyzed formula, the extensive hydrolyzed formula, and the amino acid formula. These are the different kind of formulas. The partial hydrolyzed is what we call HA formula. So they are less allergenic as you move from left to right. The amino acid is the least allergenic, and they are least tolerable as you move from left to right. So the amino acid formula has a worse taste compared to the normal intact protein. The palatability, the taste is worse with the amino acid formula, while the tolerance, you develop tolerance less if you are on amino acids, because the proteins are very simplified, so your immune system will not develop tolerance. So the more the intact is the protein, the more you develop tolerance to the milk. This is why sometimes putting a child on amino acid formula doesn't give the child the chance to develop tolerability to milk and build this tolerability over time. Of course, the cost, amino acid formulas are the most expensive one, and both the extensive hydrolyzed and the amino acid, they have no lactose and they are lactose free. And of course, as you know, lactose is important now for the GI gut, healthy gut development. So based on these guidelines, if you want to go step approach in formula-fed infant, you have a strong suspicion For cow's milk allergy, the symptoms are generalized. You start, no need to test, you start with elimination diet using extensive hydrolyzed formula for at least 4 weeks. If the symptoms do not resolve, then you change to amino acid formula and give another 4 weeks. If there is no resolution, then most probably it's not a cow milk allergy. You have to think about other differential diagnoses. If the symptoms resolve, then you have a confirmation that most probably this is a CMA formula. Okay, when to use amino acid formula? This is a common question. These are possible reasons for choosing amino acid formula over extensive hydrolyzed formula. If the symptoms not fully resolved on extensive hydrolyzed formula, if the child has flattering growth or failure to thrive, it's worth to start with amino acid formula. If the child has multiple food elimination and allergy, it's also worth. If he has severe complex GI food allergies, if he has eosinophilic esophagitis and food FPIs and severe eczema, then you may consider starting or moving to amino acid formula instead of hydrolyzed formula. What about breastfeeding and cow's milk allergy? As you know, breastfeeding we should be encouraged, and there is a bit of conflict here about what to do with mothers who are breastfeeding and they have a child with cow's milk allergy. Should they stop dairy product or continue dairy product? Most of the guidelines, they recommend to stop dairy product. But if you look at the Basaki, the British Society Allergy Guidelines, they have a bit of different view because they believe that the cow's milk protein that can be detected in the breast milk is very low, and they don't feel that the amount will trigger the allergic reaction. And they don't recommend to do dietary restriction unless the infant has shown symptoms while breastfeeding. And based on this is a study presented in the JAMA 2020, it just shows you that the amount of proteins, the beta-lactoglobulin per milliliter needed to, it's found in breast milk. You can see that it's a very low amount. And the highest single measured ever reported amount was less than 1,000, while in formula milk, it's more than 1 million nanogram per milliliter, the amount of beta-globulin. So if the mom they drink too much milk, cow's milk, she needs nearly 1,000 liters of the baby to have to breastfeed to get the amount needed to trigger the allergic reaction, especially in IgE, when it comes to IgE. To make it simple, what I recommend, I don't recommend the mother, depend on how severe, of course, the non-IgE cow's milk allergy. But if it's very severe, I would recommend the mother to try to avoid dairy product and then reintroduce and see the symptoms. If it's not severe, mild to moderate, I don't recommend. I will ask the mom just to continue to have dairy product and breastfeed and monitor the symptoms. If the symptoms are gone, or if the baby has no symptoms and he's managing, then we don't have to make the mother's life difficult to do a strict exclusion of dairy. If the child is still symptomatic, then we do a trial and then re-challenge again after 4 to 8 weeks. We ask the mom to avoid the dairy, then reintroduce the dairy and then compare the symptoms. And you'll be surprised sometimes that, yes, when the mother stops the dairy product, the symptoms improve. And then when the mother restarts the dairy product after 4 to 8 weeks, the symptoms doesn't come back again. I don't know how to explain it, but at least you help the mom not to avoid dairy for long periods of time. Okay, so reintroduction, when do we reintroduce the protein milk? The recommendation is 9 to 12 months of age and for at least, or 6 months at least, they need to avoid dairy product. You can do the reintroduction at home, or you can do it at your local pediatric clinic and service. There is also different guidelines how to reintroduce. The most famous one is the IMAP ladder, where you start with first with foods that have very low milk in them, like cookies and biscuit. And if the child is tolerating, you can move up the ladder to muffins, pancakes, cheese, yogurt, and at the end you can give the infant formula or pasteurized fresh milk. So conclusion, cow's milk allergy is the most common food allergy in children. There is confusing in presentation and challenging in finding the diagnosis, especially with non-IgE mediated. There are different useful guidelines which help in the diagnosis and management, which I recommend doctors to read and review. And elimination diet and the use of extensive hydrolyzed formula have both diagnostic and management role. And thank you very much.
So thank you so much. I enjoyed, although like it's a topic we deal with it every day, but still you managed to give us something new.
Thank you.
And yeah, and then open up for questions for now.
Hello.
Hi.
I just wonder, is there a difference in incidence according to ethnic background and the incidence?
Yes, yes, of course, there is a difference. You see cow's milk allergy differences not just in countries, as showed by this EuroPrev study, also in different ethnicities and background. I don't have the detailed data or incidence to tell you which is more common, but there's difference between Black and Caucasian, in Asian, not just in cow's milk, on all food allergies, there is a difference based on genetics and ethnicity. في مشكلة بالميكروفونز.
In the ladies who are breastfeeding with suspected cow's milk protein allergy, it sounds a simple question, but it's very practical. If you have Jordanian parents, do you advise against mansaf? Seriously.
Mansaf, for people who doesn't know what's mansaf, it is a food with high milk, but it's not cow's milk, it's goat milk. Mansaf jamid is made from goat. It's not cow's milk, but still goat, we don't recommend goat milk for babies who have cow's milk allergy, because there's a cross sensitivity between cow's milk and goat milk reaching up to 80%. But still, the advice will be the same as cow's milk allergy mothers, that don't restrict. If the symptoms are mild to moderate, just give it a go. Breastfeed, live your life, eat what you are used to eat, and see what are the symptoms. If the symptoms are mild and negligible, then I don't recommend them to avoid dairy. But if the symptoms are really bothering them, moderate or severe symptoms, then okay, fine, restrict the dairy. And in such a case, mansaf, I will restrict all that's a goat milk, but because of the cross reactivity, and reintroduce. The key is to reintroduce the dairy product again in her food and continue breastfeeding. And yes, after they reintroduce, there's a large number of mothers, they come back and say, our child has no symptoms, although we are eating dairy products. So, as I said, I don't know how to explain why this happened. When they stopped the dairy products, the child improved. When they reintroduced, the child did not have symptoms, but it happens.
Yeah, for study, research we can do about the prevalence of like which one is more prevalent for the youth. Let's do it.
Yeah, this is a very important, this is a very good study to be done. Yes, doable, easy, and more than one center can participate in it. But first we have to, yes, we have to make sure to put the right guidelines to diagnose cow's milk allergy, because we can't leave the diagnosis based just on parents self-reporting or physicians with no experience in diagnosing cow's milk allergy. And we have to do the challenge, confirm, and then yes, it will be a good, you can initiate it and we will follow you. Thank you. Thank you very much.
So the next speaker for introduction, Dr. Migdadi, great friend, American board certified pediatric gastroenterologist, hepatologist, and I think he has many more qualifications. So he speaks on all topics really good. And he's a division chief of EGI hepatology division in he's an admin staff at Cleveland Clinic, Ohio, US member of Pacific. And before coming to Abu Dhabi, he was a professor in Jordan. And his main interest is in basically research interests are feeding, difficulty eating, obesity, procedural sedation, allergic GI disorder, and symptoms. And he's a editorial of two journals, including Gastro and Hepatology. And we would be hearing from him on symbiotics, a new approach to allergy management. I think we are talking a lot lately, and there will be a few confusions which we might get rid of after this talk.
Thank you, Monica, for this nice introduction. And thanks to Basil and the scientific team for inviting me to be here. I think this is the first kind of face-to-face meeting in 2021. So I'll be talking to you today about the symbiotics and its role in the allergy management with them. I think you cannot have a presentation in 2021 without talking about COVID. And I will try to convince you that COVID is a GI disease, or at least the management of COVID can start in the gut. Then I will talk with you about the microbiome and its relation to the allergy, and then how can we approach allergy in a systematic way, approaching the pre, the pro, and the symbiotic concepts. Then I will share with you an important landmark study that was published recently. So COVID, I'm sure you read a lot and you learned about. Hopefully I will share with you something that's practical. I think we all know by now that SARS-CoV-2, which is the virus, the name of the virus that causes COVID, it has its receptors in the lungs. We all know that. What I want to share with you is two other pieces of information. The first piece, that the SARS-CoV-2 virus is typically found in the feces of the infected individuals. And many countries, what they do, they look at the sewage, and when you see a high viral load coming from a certain area, let's say downtown Dubai, you will know there's a lot of COVID patients in that area, and this is how can they initiate tracing and testing for these people. So COVID, it goes in your stool. The other piece of information, that the enterocytes, they have receptors, the ACE2 receptors there in the GI tract. And this explains why many of the COVID patients, they have GI symptoms in the form of severe diarrhea and liver involvement. So GI system is part of the COVID disease. We all know also, whenever you have any respiratory infection, COVID or others, your microbiota is altered. That's part of the disease that we are all aware of. Of course, the microbiota is not only affected by the viral illness, it's related to the diet, the environment, the genetics, and all these things as well. So, what's the relation between COVID and the GI tract? It was found, and this was established by several studies, and I share with you one of them that was published late last year. They found that people who are older, they have a less diversity of the microbiota. While younger people, say Dr. Basil, Dr. Nida, the young people, they have a more diverse microbiota. So it might be that because the microbiota changes with age and becomes less diverse, you might get more prone to diseases like that. And this is why changing the diet, improving the microbiota, might enhance your immune system. And this reminds me, and probably reminds everybody, what your grandmother used to do when you get sick. When you are sick, she starts feeding you lentil soup and other kinds of food to enhance your microbiota and help you find the infection. And that have led several researchers to suggest that changing the diet during any illness, in particular COVID disease, might enhance the immunity and decrease the severity of the disease. I'm sure many of you now are doubting all this, but this was shown and published last year in the Cell reports in 2020, and they have suggested two different scenarios. In the right side is a healthy person who has a mild COVID disease. And why they suggested that when you have a healthy microbiota down in your system here, and you get the infection, your body will have a better immunity to that, and you will have a mild COVID disease, and you will recover completely. While if you have unhealthy microbiota because of age or poor diet or any other factors, you will have ARDS, adult respiratory distress syndrome, and you get very sick. And this might explain why I'm sure all of us here, we have friends or colleagues who get COVID. Some of them are on the right side. They have a minimal disease, a little bit of runny nose, cough, and they recover completely. And other people might go to the ICU there. And maybe if we can alter their microbiota there, we can change it from being the left side, which is the sick one, to the right one. And I will show you some evidence that relates to this and the allergy, and probably it can be extrapolated to the COVID infection. Microbiome and allergy. First of all, I have a confession that we know only a little bit. In the left side, this is what's known about the microbiome. This is what we know today in 2020. While in the right side is what we don't know. And let me highlight for you at the bottom here where it says 40% of the genes, they don't have any match in the functional database. So at the best, we know half of the story, and another 40% is still to be discovered. Maybe there is other genes, other species, maybe even a different microorganisms that we don't know about these things. And this emphasizes the importance of the prebiotics, quote unquote, the food for the good bacteria, because probably it will take us many years to find out the rest of our microbiome, but at least we can feed the good ones today and make them help us and improve our immune system. I love this slide. This was published many years ago, but I think it's still valid for the most part. If you look at the left side, at the bottom there, you see a desert. And at the top of it is a forest. What this reflects, this is the intestine of an infant early in the pregnancy. Probably it doesn't have much microbiota at all. While the forest is what we will have it in the first few months of life, all the way into the adulthood. So it changes from a desert to a forest over a period of few months. Our job is to have a healthy forest there. And how can you change a desert into a forest? You have to feed the bacteria with the right mixture of the prebiotics that I will be talking about later on. While we have a lot of organisms in the forest, it is shown in the right side of this slide, the bifidobacteria is probably the most important and the most common good bacteria there, and I will mention some studies later on. I think I'm humbled to speak in front of a lot of allergists here, Dr. Sliman, Dr. Ghais, Dr. Basil, David, and others. The allergists, they teach us that allergy is the first detectable immune disorder. And I think David alluded that there would be many people, they estimated here 50% of all Europeans, they will suffer from some kind of an allergic disorder within the coming few years in 2025. And I want to leave you with a question here. Do you think we will have more than 50% or less? And the reason I'm asking this question, because over the last year and a half, we have been in lockdown, at least in Abu Dhabi. And we are using a lot of sanitization. So we, or the children, they are less exposed to antigen over the last year and a half, and they will be exposed to this antigen once the world opens up again. Will this increase your risk of allergies? And if that's true, that's very sad. Why is that sad? Because at the same time, when the allergies are increasing, look at the right side of this slide, where it shows you the risk of autoimmune disorders like multiple sclerosis, Crohn's disease, type 1 diabetes, and asthma are increasing. So in 20 years from today, in 2040 maybe, are we going to see more patients with multiple sclerosis, Crohn's disease, allergic disorders, type 1 diabetes, and asthma or not? And if this is true, this is really a very unpleasant thought. Of course, we have to show you stool pictures, but because we did not have dinner yet, this is a colorful slide. To the left side is the stool of a healthy breastfed baby without any allergy. You can see it looks beautiful, it's pink, and the pink represents our friend, the bifidobacteria. You can see a lot of healthy bifidobacteria there, while to the right is an infant who has allergy or cow's milk protein allergy, the commonest allergy in the first year of life. And you can see definitely there's less pink, less bifidobacteria there, and more hostile bacteria like the Clostridium and others. And this was shown by several studies. Here I mentioned a few of these studies. Our allergists, they teach us that babies who are born, for example, by C-section, they are more likely to have asthma and allergies. And one of the explanations for that, the C-section baby, they have a totally different microbiome than a normal born child. And there are several studies talking about that. Not only that, it's talking about the association between antibiotic use early in life and the development of allergies and asthma. And whenever you take an antibiotic, you're going to change your microbiota. And this change will take probably several weeks or even months, even after you have finished a course of antibiotics. And this have led several people to say that the allergy management is not only treating symptoms. If you have a patient with whatever allergy manifestation you have to go to the root cause of that. As I showed you, the stool of a breastfed baby in comparison with the stool of an allergic baby. If you are treating only the allergy manifestation, whether it's respiratory or skin, maybe you are not tackling the root cause of the problem, or at least the association, which is in the GI tract. All right, let's talk about the pre, the pro, and the synbiotics. The prebiotic, the old definition was, quote unquote, food for the bacteria. That's still very much a practical definition, although the more fancy definition now is a substrate that selectively stimulates the host microorganisms with confirmed health benefit. Please notice that there is few changes in the new definition. First of all, it says microorganisms, not necessarily bacteria, because now we know that the healthy gut, it has bacteria, fungus, and maybe viruses, and who knows what other organisms there. And now it does not say only GI, because our microbiota, of course, it's in our GI system, but it's in our skin, our respiratory system, in our urogenital system, and maybe other parts as well. So the new definition is a more wider definition of the prebiotics. Prebiotics, how does it work? The simplest way to remember it, it feeds the good bacteria. It makes you have a healthier microbiome. That's probably an oversimplification. The other functions of the prebiotics is actually it might directly stimulate certain immune cells, make them protective cells, and that's why the role it might happen in the COVID infection. Also, some of the prebiotics, they might block certain receptors and prevent you from having that virus or bacteria affecting your system. This is a slide with three different things to show. Look at the top right. This is a look at the breast milk and what's called or what's known as a human milk oligosaccharides. These milk oligosaccharides are present in the human milk. Today, we know there's probably more than 200 or 250 different human milk oligosaccharides in the breast milk. Two different ones, 200 different ones. Of course, it's impossible to remember the names of all these 200, but let me leave you with one thing to remember, that the most of these human milk oligosaccharides are short-chain human milk oligosaccharides, as you can see in the bottom, and the long chain are only 10%. Not only there's too many of them, but the amount is huge. It's estimated to be 12 to 15 grams per liter. That's a lot of human milk oligosaccharides there. It's even more than the protein in the breast milk. So there's a lot of human milk oligosaccharides. There is many kinds of different human milk oligosaccharides in the breast milk there. Out of these 200 plus different ones, scientists have been able to identify and study three of them, the 2FL and the LNT and the 3GL. These are the ones that's available, commercially available. When first you start seeing the commercials about different human milk oligosaccharides, they say Formula X has an HMO. People might think you go to the breast milk, extract the HMO, and add it to the formula. But that's not true. You cannot do that. You cannot do it practically. You cannot even do it ethically. So what the companies have done, they looked at the structure of these HMOs and they manufacture it in the factory or in the lab, and they add it to human milk, to infant formula. So the correct name to the ones added to the formula is not human milk oligosaccharides. They should be called human identical milk oligosaccharides, i.e. they are manufactured in the factory and you are added to the infant formula to have this positive effect. There is a lot of data about the 2FL, LNT, and 3GL. It showed some evidence that it might reduce the risk of respiratory infection or the use of antibiotics, and similar studies for 3GL in addition to the gut health of the infants. But please remember, when you have a formula with these added 2 or 3 or even 4 or 5, you are adding 2 or 3 out of 200. So you're adding a little bit that does not tell you the whole story. So if you added 3, you are missing 197 other human milk oligosaccharides that have not been added yet. This has led many researchers and scientists to come up with the GAS-FAS combination. The GAS-FAS combination is not one prebiotic, it's a combination of different molecules of prebiotics that has the function of the human milk oligosaccharides, and it resembles the breast milk in being 90% short chain and 10% long chain. So far, there is more than 50 different publications talking about the advantages of the GAS-FAS combination, reducing the risk of allergy, whether it's atopic dermatitis or others, enhancing the bifidobacteria there, our friendly probiotics there, decrease the risk of infections and the use of antibiotics, and decreasing infantile functional GI disorders like colic, constipation, and so on and so forth. So I spoke to you about the pre, let's talk about the probiotics. Does the breast milk has probiotics or no? No? Yes? Yes? Okay. Actually, yes, and probably yes, and yes. The breast milk is full of probiotics. I mentioned for you here 4 publications looking at different probiotics there. Please notice that different human milk from different ladies have a different composition. And somebody would say actually it looks like the thumbprint. So the breast milk of lady A has different bacteria than the breast milk from lady B or C, depending on her genes, her diet, her health, does she use antibiotics, so on and so forth. And you can see there's a lot of different kind of species there. Of course, nobody can remember all these names. Let me share with you the ones that was found to be more important. Again, the bifidobacteria is probably the most important, and one of them is known to be the most commonly isolated, which is the bifidobacteria brevi. Brevi is common in human milk, even from ladies from different backgrounds and different diet and different kinds of health, and it has a role in enhancing the immunity of the breastfed infant. So, the synbiotics, syn with an Y, not with I-N, it's Y-N. Synbiotic, it means in a simple way, it's adding a pro and a prebiotic together. So you're giving the bacteria with its own lunchbox so the bacteria can flourish there and you can enhance the probiotic. But actually, I think synbiotics are more than that, because when you are giving the prebiotic, you are enhancing the probiotic you are giving, as well as the good bacteria that already lives in your intestine as well. And this had led many people to say it's not only complementary, probably it's a synergistic effect with your own microbiota, your own healthy bacteria that lives there. And I'd like to say that synbiotics 1 + 1 is more than 2, because you are feeding the probiotic you are giving and your own microbiota that lives in your intestine already. So you get a synergistic and complementary effect at the same time. All right, so when we are talking about treating or managing allergy, I think we have to treat the microbiota as well as the topical symptoms of the allergy. If you are improving the symptoms of the allergy and changing the microbiota to a more favorable environment, probably you can result in a better way of doing that. This is a sensitive microbiome. Okay, so this was beautiful theory. Let's put it into clinical evidence. I will share with you now that does synbiotics maintain growth? Is it efficacious? Does it have the same or less adverse effect? Does the microbiota change? And I will conclude by sharing with you the findings of the assigned study. Let's talk about the growth. In this study, they looked at 100 different infants with allergy, and they gave them, they are non-breastfed babies, so they gave them either an amino acid formula or the same amino acid formula with synbiotics. And they looked at their growth over a period of 16 weeks of life. And this is the ratio of their growth. And you can see the growth was similar between the two groups, whether you are giving an amino acid formula or the same amino acid formula with synbiotics. Okay, so growth-wise, it's okay. How about the efficacy? This is about the infants with cow's milk protein allergy, the IgE type, and they gave one group amino acid formula and the other group the same amino acid formula, but with synbiotics, and they found the efficacy is the same in the two groups. Both of them have responded. They should respond, of course, 100%, and they have no more IgE-mediated allergic reactions. Let's talk about the adverse effects, and that's where I think the strength of these studies have shown. The pointer does not work in this kind of screen. If you look here at different times, if you look at adverse effects, whether it's infections or is it medications used for GI symptoms or antibiotics, and this is the different times from 0 to 16 weeks. The third column is the amino acid formula. The fourth one is the amino acid formula with the symbiotics and then the p-value. As you can see, when you are using a formula, the amino acid formula with symbiotics, you have less adverse effects, you have less usage of medications for functional GI disorders, and you are using less antibiotics for that. So in other words, it improves your gut health and it decreases your risk of infections and your need to use antibiotics. I'm sorry, the bottom line doesn't show the reference there. All right, let's look at the effect on the microbiota. Again, the same design of the table. As you can see, your good bacteria, the bifidobacteria, will be more in the group that have received the amino acid formula with the symbiotics. Look at week 16, in the amino acid formula, it was 13%, while in percentage, I mean, and the one with the symbiotics, the bifidobacteria ratio have increased from 13 up to 51% increase. The reverse is for your bad bacteria, for Clostridium, it decreased like in the amino acid formula 17%, in the symbiotic formula is down to 7%. So definitely when you give symbiotics, it will increase your good bacteria and suppress your bad bacteria. All right, let me conclude by the ASSIGN study. The ASSIGN study is again using an amino acid formula with symbiotics, but this time on the non-IgE, which is, as was mentioned by Basil, is the commonest form of cosmic protein allergy in infants. It was a multi-center, double-blinded, randomized control done in different parts of Europe, UK, Italy, Belgium, and Sweden. And again, they divided them into the amino acid group, amino acid with symbiotics, and of course, compared them with the breastfed baby, which is the gold standard. The study was run over 8 weeks period of time. The primary outcome was looking at the bifidobacteria in these infants. The secondary outcome was the stool characteristics and the gut immune health markers. And as another factor they looked at it is the clinical symptoms and the safety, of course, and medication use and the growth of these infants. So, non-IgE fed baby, non-IgE cosmic protein allergy, amino acid formula with symbiotics, amino acid formula just without symbiotics, and they compared them with the breastfed baby. Okay, in this graph you can look at different parts about the infant-like bacteria, the good bacteria, which is in pink color, and you can see the ones in the pink is the amino acid with the symbiotics, and you can see that the bifidobacteria or the healthy infant-like bacteria is more if you are feeding the infant a formula which is enhanced with symbiotics. And the adult bacteria, which is the hostile bacteria, you can see it's decreased in the infants who were fed amino acid formula with symbiotics. Looking at different GI symptoms, in both groups it has improved, and maybe some improvement, slight improvement in the infants who were fed the test formula, which is the amino acid with the symbiotics. Looking at adverse effects, let me highlight for you the most important. They found that the infants who were fed the amino acid formula with symbiotics, they have 0 ear infections in comparison with 20% in the other group, and similar findings in the other infections and any adverse effects, although the p-value was not significant except for the ear infections. Then they looked at their usages of other medications, whether they were skin medications, and they found that in general, any use of any dermatological medications were much less in the symbiotic group versus the amino acid group. And here they looked at different kinds of moisturizer, anti-pruritics, antiseptics, and steroids and emollients and others as well. So Okay, and you can see the p-value is significant for some of them, but not necessarily all of them. So in the ASSIGN study, they concluded that the microbiota is changed favorably. If you are giving an amino acid formula with synbiotics, you have a healthier microbiota and less of the hostile bacteria there. There is a decreased incidence of infection, in particular bacterial infections like otitis media, and they have shown reduction of the use of different kinds of medications, in particular skin-related or eczema-related medications. So, ladies and gentlemen, I'd like to conclude by saying allergies are there. Probably it's more common than what we think, and probably it's increasing in incidence and prevalence, and maybe with the COVID, it might increase as well. Allergies, they have short-term as well as long-term implications, and I think to treat allergies, we have not only to treat the local disease, maybe the microbiota should be targeted as well. I showed you 3 different concepts from the pre, the pro, and the synbiotics. All these are immune active components that might shape the allergy and decrease the risk of allergies. And I shared with you several studies talking about the advantages of an amino acid formula with synbiotics versus an amino acid formula alone, not only in the GI tract, also in the microbiota, as well as the decrease the risk of infections and decrease the need for skin medications. Thank you very much. I will be happy to take any questions.
Thank you, and I'm also so good for questions. Before anyone asks, can I ask a question? Yeah, regarding we all know that the babies were born cesarean after about this dialysis. So, would you suggest giving pre and probiotic to the moms or to the babies, or how do we see to the solution to the problem?
Yeah, well, thank you very much. We know the microbiota is different by the nature of the birthway, natural delivery versus C-section. That's one. Second, ladies who are having C-section are more likely to take antibiotics that will further alter their microbiota as well. What's the best formula to feed an infant who's born by C-section? Is probably breastfeeding. Breastfeeding that will give them the pre, the pro, and the synbiotics and postbiotics as well there. If the baby cannot be breastfed for whatever reason, although 99% of them, they should be able to breastfeed, then probably giving a formula enhanced with a pro, pre, or postbiotics might improve their microbiota.
No, I mean,
but not to the mom. To the mom, it's probably too late.
Yeah.
Yes, بس. سؤال مناسب لا سؤال ثاني.
Thank you, Muhammad. As you mentioned, the best option to give formula enriched with the pre, pro, and symbiotic.
Yes.
If we don't find this formula, can we add the symbiotic on the formula? Like we know we have probiotics in the market, which can we use? Is the effect the same as adding these externally to the formula, the same effect as when it is already produced by the formula itself from the factory?
Excellent question. Your question is there an advantage of adding probiotics to the feeding, not through the infant formula? Unfortunately, this had not been studied. There's no studies about that if you give it as a drops or as medications. All the studies have been using an infant formula with the pro, the pre, and the postbiotics added.
So it seems there's no more questions.
All right, go to coffee break.
Go for a coffee break.
Thank you.
Come back with 2 more interesting talks. So expect you to be back. Thank you.
Yes.
We'll finish up by talking about the utility of clinical guidelines. It's not moving anymore. The slides are not moving. All right, so when we talk about drug allergy or drug hypersensitivity, the terminology is confusing. So we use a lot of words to mean the same thing. So we have drug hypersensitivity, IgE-mediated reactions, adverse drug reactions. Sometimes we use the word susceptibility, sensitivity, and sometimes we call it drug allergy. So what are adverse drug reactions? Adverse drug reactions include all unintended pharmacological effects of a drug, except therapeutic failures, intentional overdose, abuse of the drug, and errors in administration. They are commonly encountered in both the inpatient, so up to 15%, and the outpatient setting, up to 25%. So the adverse drug reactions not only result in a major health problem all over the world, but in the US, because we have more data, it is estimated that it costs around $6,685 per event, so per adverse drug reaction per patient. And it's really responsible for over 100,000 deaths per year in the US. I'd like to start first by this pamphlet that you typically would see in pharmacies when they dispense your medications. And what I really like is this is a simplified way of really differentiating between drug allergy and intolerance. So a drug allergy is a rare condition that usually involves your immune system. It can be mild, but it can also be life-threatening. And usually when you have a drug allergy, you should not receive the same drug again ever. A drug intolerance, on the other hand, usually does not involve your immune system, and it's usually a result of an adverse effect from the drug. If you have a drug intolerance, you may be able to continue with the drug, either by taking it differently or taking it with some food, for example, or just changing the way you take it. And sometimes drug intolerances simply disappear with time. Now, the classification of adverse drug reactions, typically there's several depending on where you read about it, but mostly you have type A and type B. Type A are predictable and preventable adverse drug reactions. They're usually dose dependent and related to the known pharmacological action of the drug. They can occur in anyone, and there's 4 different subtypes. For example, we have toxicity and overdose with, for instance, aminoglycosides leading to nephrotoxicity or hypoglycemia from insulin. Sometimes it's a side effect, so sedation from antihistamines. Sometimes it's a secondary effect like diarrhea from antibiotics or tremor with albuterol. And then also sometimes the reaction can result from interactions between, let's say, an example is theophylline toxicity with concomitant erythromycin use. For type B reactions, which are really our main concern today, the type B reactions are usually unpredictable and not preventable. They're usually dose independent and unrelated to the known pharmacological action of the drug. And they usually only occur in susceptible individuals. Immune-mediated drug hypersensitivities are usually what we refer to as drug allergies. And they typically involve antibodies, anti-cells, and the immune system. Non-immune mediated hypersensitivity reactions involve four different types, and we'll talk about these in a bit. So you all know this. I'm not going to dwell on this, but I'm just going to refresh your memory. You all know from med school that we have 4 different types of hypersensitivity reactions. Obviously, there are subtypes, but for the sake of this presentation, I'm not going to go over this. For type 1, which is usually IgE mediated, you have the allergen. You have the allergen that would basically cross-link your IgE antibodies at the surface of mast cells and basophils, leading to degranulation and release of histamine. And usually the reaction is immediate and within a few hours. And what you typically see in a patient is a wheal and flare reaction. Examples of type 1 reactions are asthma, rhinitis, eczema, what have you. Type 2, type 3 are involving antibodies, mainly IgG and IgM. In type 2, it's an antibody-dependent cellular cytotoxicity that occurs at the cell level. There's also complement and neutrophil involvement, and it typically occurs 5 to 8 hours later. And there's lysis and necrosis, and an example is immune hemolytic anemia. Type 3 is also involving IgG, IgM, but it's the immune complex itself that deposits in the organ and causes the damage. Usually it's 2 to 8 hours, but you can also have, typically it's 1 to 4 weeks. And you see erythema, edema, and an example is serum sickness. In type 4 you have your T cells involvement, and it's usually delayed. And the classical example is the PPD test that typically occurs 48 to 72 hours. So that's why we tell our patient after a PPD test to come back in 48 hours for the read. Now, the type B non-immune mediated drug hypersensitivity reactions, you have drug intolerance, which is usually an undesirable pharmacological effect that occurs at a low and sometimes subtherapeutic dose of the drug. And this is usually without any underlying abnormality of the metabolism or excretion or bioavailability of the drug. Like, for example, tinnitus with aspirin. Drug idiosyncrasy happens when you have an underlying abnormality. And a good example is hemolytic anemia in G6PD deficient patients when they take Dapsone. Pseudoallergic reactions can mimic IgE-mediated reactions, and they're due to direct release of mediators from the mast cells and basophils, and they do not require a preceding period of sensitization. This is most commonly seen with contrast, so the radio contrast the iodine contrast that we take for CT scans, and opiates. So what are the risk factors of having a drug allergy or drug hypersensitivity? And when I say drug allergy or drug hypersensitivity, I'm usually referring to the immune-mediated ones. So we have drug-specific factors and host-specific factors. For drug-specific factors, the larger your molecular weight, the higher the likelihood for you to have a reaction. The dose, so when you give a single dose of prophylactic antibiotic versus a repeated and prolonged course of antibiotic, you have a lower likelihood of developing allergies. So prolonged is usually associated with more allergies. If you give it PO, your risk of developing allergy is less than if you give it IV or cutaneously. The repetitive exposure, and this is very, very important because a lot of patients will tell you, I've been taking this medication my whole life, so definitely it's not this medication. Well, repetitive exposure is actually associated with a higher risk of you developing drug allergies. So it's really the other way around. Sometimes when you give, we all know, pediatricians specifically know about the amoxicillin rash when you give it when you have a concomitant EBV infection. For host factors, for penicillin specifically, we know that children and elderly have less penicillin allergy than anyone in between. We also know that women have more drug allergies for a reason or the other. And we know that atopy is associated with multiple drug allergies. Sometimes the underlying diseases such as SLE, HIV puts you at a high risk for drug allergies, and then some genetic polymorphism can also put you at a high risk for that. The epidemiology in kids, really, there's a lot of different studies, but these are really everything I could find. So there's really not a lot of studies. And drug hypersensitivity or drug reactions, adverse drug reactions vary from 2.8 to 16.8%. But when you actually verify the drug reaction, only 4% had true drug allergies. The most common culprit in kids is beta-lactam antibiotics, NSAIDs, and vaccines. So really, those are the most common ones. What do you see in your patients? The most common presentation is the maculopapular rash that you see in the first picture. And it's usually associated with a lot of different drugs. But you can also see urticaria, pruritus, erythema, angioedema, not only of the face, any part of any swelling in any part is called angioedema. So it's not just laryngeal edema. You can also see fixed drug reactions, such as with sulfonamides and carbamazepine. The severe cutaneous adverse reaction that you see here, those are basically a bit different and delayed. And examples are acute generalized eczematous pustulosis, which you see in the first picture. You have Stevens-Johnson and 10, and you have also serum sickness. Now, the severe cutaneous adverse reactions are really a wide spectrum of diseases with a lot of different phenotypes, and the common mechanism, or there's a lot of different mechanisms, let's say. But the common thing about these reactions is they typically occur later and they're not immediate. And the common treatment for these reactions is basically withdrawal of the drug and then anti-inflammatory and supportive care. So why should you care about drug allergy and labeling your patient with drug allergy? I'm going to use the penicillin allergy as an example and give you some data. Only 10% of self-reported penicillin allergy truly reflect the inability to take penicillin. So only 10%. So in this room, probably just half a person would have, or 1% would have true penicillin allergy if all of you say you have penicillin allergy. And patients reporting penicillin allergy will receive alternative antibiotics that are broader, more toxic, less effective. So, and they usually have greater length of stay, hospital stays. They have increased rate of infections with C. diff, VRE, MRSAs, and they have increased cost of care. And really, allergists can easily address this with validated diagnostic testing. So you can see here different numbers where you go from using a lot of broad spectrum antibiotics to really up to 0%. So you have a patient in the clinic, you want to assess this patient and figure out whether he or she have an adverse drug reaction. A good history is really the key to diagnose this. So you start by obviously talking about the name of antibiotic. When during the course did this stop? A very important question is, did the reaction or did the hives, did the rash disappear completely immediately after you stop the reaction, stop the drug, or did it persist for 2 or 3 weeks? So is it just chronic urticaria exacerbated by the infection, or is it truly the drug that's causing this? So characteristic of the reaction, previous exposures, usually you need previous exposures to get sensitized and decide that you're allergic. And then the management required for the reaction. So did it go on its own? Did the patient require antihistamines, steroids? Did they require epinephrine? And then a detailed review of records is really important when the documentation is done properly. And really when you're dealing with, if you're dealing with a patient who's reacting to a drug, it's really, really important to document the timeline because that's really helpful eventually. So is the adverse drug reaction an allergic one? Are symptoms compatible with an immune drug reaction? Is there a temporal relationship? And if there's no other, is there any other clear cause for the presenting symptoms? And then a good question is to ask whether skin testing or lab findings are compatible with drug hypersensitivity. So you did that, you have a good history, excellent. So what can you do with this patient? What tools do you have after a good history? So skin testing, there's two types of skin testing. You have the skin prick testing and you have the patch testing. You have the in vitro testing and you have the drug provocation test. So the oral challenge, this is the gold standard to diagnose the drug hypersensitivity or drug allergy. And then finally, you have desensitization, and we'll talk more about desensitization. So in skin prick testing, what happens is basically you put the extract on the forearm, and then if the reaction is negative, what you're really watching for is a wheel and flare reaction. You're pricking through the drug that you're applying on the hand. And if it's negative, you go to intradermal testing. And positive results usually suggest the presence of a drug-specific IgE antibody. Negative results, though, do not rule out an IgE-mediated reaction. So that's important because we always end up challenging these patients. 5% of patients with completely negative testing will still react. So that's really important for us to know that and to move on to an actual challenge. Penicillin is the only drug that has commercially available extracts for testing. However, we do have a lot of published non-irritating concentration. It's really important to have non-irritating concentration because these drugs, again, are not supposed to go on the skin. These are meant to swallow or go parenterally through our IV. So there's a lot of different non-irritating concentrations published out there. The drug patch testing, which I typically do not do because of lack of consensus regarding the appropriate drug concentrations in carrier diluent, and there's really not a lot of studies looking at the patch drug testing. It's less sensitive than the intradermal testing, and the only, I think, useful place they have is when we're looking at severe cutaneous reactions. Now, the in vitro testing, they exhibit a varying sensitivity depending on the drug that we're using. They can complement in vivo testing. These assays are of critical value in severe cases where you cannot do oral challenges. And for me, it's really important to understand that there's a potential promise for this IV in vitro testing. But at this point, really, they have a lot of limitations, and I wouldn't really rely my diagnosis depending on these testing. So when you're dealing with an immune-mediated drug hypersensitivity reaction, in the acute phase, you can get a tryptase level or a histamine level. And that will help you diagnose an anaphylactic reaction. Now, this is especially important for people who work in the AR, not because they don't know how to recognize an anaphylactic reaction, but because it will help us later on figure this out. So comparing an acute rise in the tryptase within the first 4 to 6 hours, and then comparing it to baseline later on. At the resolution phase, we have specific IgE testing for a lot of different drugs. But again, as I said, the sensitivity and specificity really varies tremendously depending on the drug involved. We also have the basophil activation test, which we don't use a lot. And for the non-immune mediated drug hypersensitivity reactions, usually we depend on measuring the cellular lymphocyte proliferation, or we end up measuring the cytokine release. But again, these are not done routinely. Drug provocation or challenge test is the gold standard for evaluating your hypersensitivity reaction. And what it involves basically a stepwise administration of a drug to a patient who is unlikely to be allergic. So you're doing this only basically to rule out the allergy. And people that you know are probably not allergic. There's really no evidence-based guidelines regarding the optimal number of steps. Some people will do it in 2 steps, some people will do it in 10 steps. So I typically do a 2-step graded challenge where I give 10% of the dose, then give the rest of the 90% of the dose. And the intention, again, is to verify that the patient will not experience an immediate adverse reaction to a given drug. And it's really meant to reassure patients and physicians of the drug safety and not intended to induce drug tolerance when as compared to desensitization, which we're going to talk about. Desensitization, on the other hand, it's the procedure which allows your patient allergic to a drug to take it safely. So I'm allergic to Augmentin. I have a bacteria that can die only with Augmentin. So I absolutely need Augmentin. This is when desensitization can be done. So conceptually, it's dedicated for IgE-mediated reactions, but it has been used for non-IgE-mediated reactions, like with the taxanes and some delayed type 4 reactions. It's indicated only if the patient is confirmed or highly likely to be allergic. It's indicated when there's no alternative treatment and when the alternative treatment are considered therapeutically inferior or more toxic. Or if they're also only indicated under direct observation and with a team who's prepared to treat anaphylaxis if it occurs. Again, it's contraindicated in any of the severe life-threatening immunocytotoxic reactions. So all the delayed reactions, the severe cutaneous adverse reactions like AGAP, Stevens-Johnson, TEN, all of those are contraindications for both drug challenges and desensitizations. So in desensitization, it involves the gradual introduction of increasing amounts of a drug over hours to days, leading eventually to tolerance, so inducing tolerance. What does that mean? If the treatment is stopped, the patient will require to undergo a new desensitization. So we're not curing a drug allergy, basically. We're just making sure that this patient can get this drug only temporarily to treat the actual infection or to get his chemotherapy. Usually, if the patient stops the medication for 3 to 4 half-lives of the respective drug they're taking, that's when they're no longer desensitized and when they have to, they become allergic again. Protocols that are usually applied to adults are also applied to children, and the difference is just the cumulative dose. Pre-medication, which is a very common question that I get. So first of all the medications that the patient is taking should be continued except for beta blockers because they can interfere with the treatment of severe hypersensitivity reactions. I typically skip the dose the night of the procedure and the morning of the procedure. And if I absolutely can't, I just stop the morning of the procedure. And there's a lot of different pre-medication regimens out there. Some say use it, some say do not use it, but we know that the European Network of Drug Allergy and the EAACI, which is the European Allergy Society, recommends to avoid pre-medications with corticosteroids or any antihistamines, because that actually masks the signs of hypersensitivity. So some might argue that, but the bottom line is for us to actually give this medication to the patient. So why do we care if we're masking it? Well, because really to avoid any unneeded or delayed reaction, unneeded desensitizations in the future. The route of administration and dosing of the desensitization, usually if you're gonna give IV ciprofloxacin, then you use IV. If you want to give PO, then you desensitize with the PO. The starting dose depends on the severity of the actual reaction that's reported. You can start with 1 in 1 million or 1 in 1,000 concentration. I usually start in 1 in 1,000 because from the data that we have, usually reactions are extremely rare at these lower concentrations. And the steps range from either doubling the dose, you can have 2 times to 10 times the previous dose. Usually the most common one is doubling the dose, and the steps go from 12 to 20 steps, and the most common one is 12 steps. So doubling the dose every 15 to 20 minutes for 12 steps total. These are just two different examples of desensitization protocols. The one on your left is for penicillin. The one on your right is for a tetanus vaccine. So you can also desensitize to vaccines. So being allergic to a vaccine is not really a reason for the kid not to get his vaccine or her vaccine. And how does this work? The exact mechanism may remain poorly understood, but we know that there's two things going on here. So if you look below, so we know that what we're doing is we're inhibiting the mast cell degranulation and cytokine production. What we're doing is we're giving a low dose of the drug, and this low antigen is lowering the threshold of activation. So what happens eventually is there's internalization of the receptors for that specific drug on the surface of the mast cells, and thus they become more stable and they don't degranulate anymore and they don't cause symptoms anymore. There's also drug-specific T-cell proliferation reduction, meaning that there's also activation of the T regulatory cells. You know that the T regulatory cells, the main job of these cells is to give us interleukin 10, which is anti-inflammatory. So we know that interleukin 10 is increased, thus everything reacts less. And we also now know from new studies that we have also involvement of interleukin 35, which is a new interleukin from the interleukin 12 family. So quickly, we already touched upon this, but the difference between, because I said desensitization and graded challenge is a stepwise dosing. So what's the difference here? Desensitization, you're starting, the patient is allergic. Graded challenge, the patient is probably not allergic. And then when you're doing the desensitization, you're really targeting to modify your immune system versus in the challenge, you're just proving that this patient is not allergic. You can do it PO, IV, IM for both. The starting doses in desensitization are usually much less. And then desensitizations usually require more dose, more steps than the challenges. And at the end, at the end of a desensitization, you need to continue the drug to maintain that induced tolerance. Versus in the challenge, if the patient successfully passes that challenge, then they're no longer allergic. So you remove that from the record and you just give the next dose fully without any challenge or desensitization. And then, as I said before, they're both contraindicated when you have a non-IgE mediated reaction, such as Stevenson and TENS. I'll finish up my talk with 2 slides about the utility of clinical guidelines. And again, using penicillin because it's really the most common one. So penicillin allergy is usually reported in 10% of the population and up to 15% of inpatients. That's really a lot. And it's associated with use of alternative antibiotics and broader spectrum and higher risk of infections with resistant pathogens. So after formal allergy evaluation, including penicillin skin testing, between 90 to 99% of patients with reported allergy can tolerate penicillin. So that's huge. What we have here, this is a study from Blumenthal and her group from Mass General. And what they did is they created a guideline that they implemented to assist the provider in getting the allergy history and prescribing antibiotics for those patients who report that they have a penicillin or cephalosporin allergy. And what they did is they used a standard 2-step graded challenge or test dose, they called it. And they compared treatment 21 months before the guideline implementation versus the 12 months after the guideline implementation. This guideline basically, I don't know if you can see it well in the back, but you have for type 2 and type 4 reactions, basically avoid using it altogether. If absolutely necessary, then at that point you would involve allergy team for further discussions. If you had a mild reaction and your patient is telling you that they have penicillin allergy, you can use a full dose of 3rd or 4th generation cephalosporin without even testing. You can also use penicillin or 1st and 2nd dose cephalosporin by a test procedure. Test dose procedure is the graded challenge that I was talking about. So 10% of the dose, then 90% of the dose. For those patients in between who had really severe reactions, that's when you can do a challenge with a third or fourth generation cephalosporin, or if you absolutely need penicillin, that's when you involve the allergist. So this was associated with a 7-fold increase in the number of test doses, obviously. But the most important thing here is without any new adverse drug reactions. So a lot of patients basically had the ability of taking penicillin and cephalosporins without involving extensive studies and allergy consults. So the patients were assessed with this guideline, and obviously alternative antibiotic exposure was decreased. This is the first clinical guideline really looking at the pediatric population, and this was an electronic guideline. And this was basically meant for pediatricians like you. And what they showed here is out of 94 or 96 reported penicillin allergy, 62 could be actually challenged and safely, they were able to safely take penicillin just by following this simple questionnaire without any increase in adverse reactions. So basically the utility of clinical guidelines, again, that all the guidelines cannot be applied to your own different practices or institutions. You have to kind of tailor it to your institution and your daily practices. But I encourage every one of you to actually work with allergists to kind of come up with these algorithms, because you can really just follow those things and save a lot of and decrease a lot of mislabeling of drug allergies. In conclusion, the terminology is super wide. We need to work on that. But when you have a suspected drug hypersensitivity, again, a detailed history is extremely important, and detailed documentation is really needed whenever you have the option to do that. And once you have that history, then you have a lot of tools that we still need to actually work on, but you have the skin testing, the in vitro testing, and the gold standard is the drug provocation test. Once you have a confirmed drug hypersensitivity reaction, then the treatment is drug avoidance, but not only drug avoidance. It's basically also you need to educate your patient about cross-reacting drugs. So just the other day, I had a patient telling me, I am penicillin allergic. My parents tell me that I had a rash and I was rushed to the hospital when I was younger. But then I said, did you ever take Augmentin? Yes, 2 weeks ago I had Augmentin. So obviously that patient is not penicillin allergic. So you really need to educate your patients about cross-reacting drugs and tell them that they have the option of getting desensitized whenever it's indicated. And then, you know, we do have all these tools. So please help us decrease mislabeling drug allergies and have allergists all around you. So utilize us. Thank you.
Questions? Thank you, sir. Just want to inquire about, I was looking so there are a lot of scorpion bites, and so in the cases of giving serum, where we have to make this, and just giving into 10 minutes connected flow, maybe just going, but some patients have, like, suppose next time the same person get bitten by a scorpion and you want it to go. Because they usually follow the same protocol, or there's something different in that.
No, so that's, thank you for that question. That's completely different. So this is more like the allergic rhinitis patients trying to desensitize to allergens. So that's a long-term treatment, and that's a 3 to 5 year treatment. So we do that with the honeybees and the other venom. So I'm not aware of actual desensitization that was actually tried for scorpions, but it would be different. And in that case, the desensitization is long lasting. It's completely different than the drug desensitization, which is short lived. Yes. Of course. So, excellent question. So if you have a patient who is truly allergic, then you expect them to actually react. And what you do is you treat that reaction or that anaphylaxis. And yes, I've had patients anaphylax. You treat that anaphylaxis, and then what you do is you repeat the same dose after all the symptoms subsided. The best time to actually push through a desensitization is right after a desensitization. So that's extremely important to explain to the patient, because if you didn't explain to the patient is going to be so traumatized by his reaction, and the first reaction would be, I don't want to continue, I want to stop. But if you explain this beforehand, and obviously it's a lengthy discussion that you have with the patient and the family, of course, because all the family will ask the same questions. So you explain that this is what's going to happen. And usually it's given in small doses, and you kind of catch the anaphylaxis at the beginning and try not to leave it and progress to, but I've had to use epinephrine several times, so. There are a few, I haven't really had, I had one patient react 3 times during a desensitization. I was almost ready to give up, but then I pushed through, and it was successful. But really, you really need the cooperation of your patient, because, anaphylaxis 3 times in a matter of 6 to 8 hours is just a lot for the patient. So it's just really a matter of a great discussion before you actually go through this. Thank you.
Thank you very much. Actually, I'm happy to present Dr. Hisham Hamdan. And Dr. Hisham Hamdan is a consultant pediatric allergologist and programs at Al Sheikh Hospital. He did his training after finishing his medical school in Jordan University. In New York, then he worked as a pediatrician for a while, and he moved back to the Middle East to work in Jordan and Saudi Arabia. And he went back to the States to do his pediatric subspecialty at Southwest Hospital in Texas. And I know for sure this is a very super busy hospital. Then after that, he worked as a consultant pediatric allergologist in the States. He was close to me in Dayton, Ohio. I used to be in Columbus, and then after that, he moved here to enrich the pediatric department at the Children's Hospital. Welcome aboard, and we are happy to have him as a speaker today.
Thank you, Dr. Hamza, for the introduction. Just a quick note, I'm a consultant pediatric pulmonologist and sleep medicine. I work at Gilead Children's Hospital, and it's a pleasure to be here today. Thank you all for being here today, whether in person or virtually. And I also thank the organizing committee for inviting me to speak about a topic that I like a lot, which is sleep medicine and sleep apnea. So during this presentation, I will need internet access. I'm not sure how I can do that from here. Can you show me how to access the internet? Disclosure, I have no actual or potential conflicts of interest in relation to this presentation. There will be a few questions during this presentation, and it is totally voluntary. If you wish to participate in the audience response system, you are kindly asked to either scan this QR code or go to this website and enter this code. And then as I activate the questions, you will start seeing them on your smart device, and you can answer, and then we can see how many answers were for which choice. Okay. So how have to go through this to kind of switch. Okay, so I just need a few seconds. Okay. Sorry. It's okay. I will open. I'll need both. It's okay. They will show under their smart devices. So where do I log in? Okay. Few seconds. I should be done. Continue. Okay, my password. Check. Okay. 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 Let's take this out. Start session. Okay. So we're starting the session. Okay, good. So how do I go back to your PowerPoint? So you can join on this whether you are at home or virtually. Okay, good. So I need to switch again 4 times. And then I switch. Okay. Okay. Okay, good. Thank you. Thank you very much. Okay, so the learning objectives of this presentation will be to talk about the American Academy of Pediatrics and the American Academy of Sleep Medicine. The American Academy of Pediatrics and the American Academy of Sleep Medicine recommendations with regards to safe sleeping habits. It will also include talking about summarize the relationship between Down syndrome and obstructive sleep apnea, describe what is meant by delayed sleep-wake phase disorder, define excessive daytime sleepiness, and describe the clinical features of narcolepsy. All right, so a quick note about the field of sleep medicine. The field of sleep medicine is comprised of 6 domains, basically. The first domain of sleep medicine deals with sleep disordered breathing, which includes disorders such as obstructive sleep apnea, central sleep apnea, hypoventilation, upper airway resistance syndrome. The other domain in sleep medicine deals with circadian rhythm disorders, which are generally referred to as disorders of the biologic clock, which include delayed sleep phase, advanced sleep phase, not 24-hour sleep phase, shift work disorder. The third domain in sleep medicine includes parasomnias, which includes things like sleepwalking, night terrors, rhythmic movement disorders like head banging, for example. All right, and then the fourth domain is disorders of insomnia. Fifth domain, disorders of hypersomnia. And then the sixth domain is restless leg syndrome, which is kind of very rare in children. So I will return this, please. Okay. How do I move to the next slide? Here, this one? Okay. It's not moving. Okay. So I will move on to the first question. So the first question says, the mother of one of your patients asks you for recommendations about the amount of sleep her son should get. Okay. All right. So, okay, I will need to switch to the keyboard. Is that possible? Control tab, right? Okay, but it's not switching. See, I go like that, it brings me back here. This one, yeah. Okay, yeah. So the mother of one of your patients asked you for recommendations about the amount of sleep her son should get. Which of the following statements you are most likely to include in your discussion? So A, infants 4 months to 12 months old should get 11 to 14 hours. Children 3 to 5 years of old should get 10 to 13 hours, including naps. Children 6 to 12 years old should get 9 to 12 hours. Teens 13 to 18 years of age should get 8 to 10 hours, or all of the above. So which ones? Okay, so we have how many answers so far? So far we have how many people? So we have 4 answers, and they are all, I'm not going to say what they are. So we'll give it a few more seconds. All right, so I will go to this one here. Okay. Yeah, so this is a question. So the answer to this, and everyone's got it right, F, all of the above. So to promote optimal health, the American Academy of Sleep Medicine recommends that children should get the following amounts of sleep on a regular basis. So 4 to 12 months of age, 12 to 16 hours, including naps. 1 to 2 years of age, 11 to 14 hours, including naps. Children 3 to 5 years old, 10 to 13 hours, including naps. 6 to 12 years of age, 9 to 12 hours. And this age group misses a lot of sleep, by the way. And then, of course, the teens, 13 to 8 hours, should get 8 to 10 hours. And this is the second group that misses a lot of sleep. So this is with regards to the amount of sleep. Some other important guidelines by the American Academy of Sleep Medicine and the American Academy of Pediatrics. Adequate sleep duration for age on a regular basis leads to improved attention, behavior, learning, memory, emotional regularity, quality of life, and mental and physical health. So this is important to recognize that if a kid misses sleep or is not sleeping adequately, it's not just they're going to be sleepy during the day. They will have many other problems that's going to happen in the acute, subacute, and during the chronic term. Not getting enough sleep each night is associated with an increase in injuries, hypertension, obesity, depression, especially for teens. All right. All screens should be turned off 30 minutes before bedtime. TVs, computers, and other screens should not be allowed into the bedrooms. Now, of course, now with COVID and online teaching, this is maybe challenging to accomplish. All infants and young children should have a bedtime routine. And what is meant by a bedtime routine is a period of time that's before bedtime. Let's say bedtime is 9 p.m., then between 8:30 to 9 p.m., that's the bedtime routine. And that is a half an hour of structural activities that repeat every night, and they are intended to get the kid ready for sleep, such as taking a bath, brushing the teeth, wearing the pajama, reading, and then going to bed. And this is important to attain adequate sleep. All right, as part of routine health maintenance visits, so this is important for general pediatric practice, that as part of routine health maintenance visits, clinicians should inquire whether their patients snore. They also should screen their patients for quality of sleep at night. And this is based on the American Academy of Sleep Medicine that's endorsed by the American Academy of Pediatrics recommendations. How do you screen for sleep in clinic? Let's say a kid is coming to you for their 5-year-old vaccine visit, routine immunization visit. So how do you want to screen for their sleep? The best instrument I would recommend is to use BEARS. BEARS stands for bedtime issues, exercise, excessive daytime sleepiness, night awakenings, regularity and duration of sleep, and snoring. There are a bunch of other screening tools that you can do, but BEARS is the best one, I think. And this table here shows you how to apply, or explains how to apply BEARS in a clinic visit to screen for any sleeping problems. And there are examples of different questions you can give for different age group patients to ask about bedtime problems, excessive daytime sleepiness, awakenings at night, regularity and duration of sleep, and snoring. And if anything comes positive, then you can ask a few more questions about that and decide what you need to do to manage this problem. But the point is, when kids come for routine visits, you know, we look at their immunization card, we look at their growth, their development, we look at, we ask parents about their nutrition, but sleep is also very important. So screening about sleep, when does their kid go to bed? What time does they wake up? Do they wake up sleepy? Are they sleepy during the day? Do they wake up during the night? Do they snore? Do they have problems going to the bed? Do they resist going to bed? That's important in screening because sleep is very important. Most of the kids we see, the majority of their life is spent sleeping. So you need to make sure that that's actually a good quality sleep. So I'm sorry about the colors here, but I got this right out of Google. This is an important slide. So this is the baby safe sleep habit recommendations. This is endorsed all around the world. Of course, number one, you need to have a safe cot or a safe bed. The mattress needs to be firm, no soft mattresses. You should have the baby sleep on the back to sleep, of course. Make sure that the head and face are uncovered. If you're using a blanket, make sure it is low, below the nipple line. And then do not use any extra soft objects, pillows, toys, teddy bears inside the baby's cot. Do not use a water bed or a bean bed. Do not share the same sleeping surface with your child or your infant. So there should be different separate surfaces. So the mother is sleeping on the bed, the baby should be sleeping on the cot. So no surface sharing. And of course, to reduce the incidence of SIDS, then things like breastfeeding, making sure there is no secondhand smoking in the house. So this is the baby sleep safe recommendations. All right, so second question. The mother of one of your patients, sorry, this is the first question. The answer is all of the above. Second question. Again, if you've already went to this website, you only need to do it once. You don't need to do it with every question. So a 14-year-old girl, so now we're moving to the other extreme of sleep medicine. A 14-year-old girl feels sleepy all the time. She goes to bed at 9 p.m. on school nights, stays in bed doing nothing, and falls asleep at 12 midnight. She wakes up sleepy at 7 a.m. She does not nap. On weekends, she sleeps from 1 a.m. And she wakes up the next day at 12 noon. When she goes on spring breaks, her schedule becomes from 2 a.m. to 12 noon. She does not feel sleepy during the day on spring breaks. Her physical exam is normal. Based on this information, what is the most likely diagnosis? Restless leg syndrome, sleep disorder, breathing, like sleep apnea, delayed sleep phase syndrome disorder, behaviorally induced insufficient sleep syndrome, or primary insomnia. Let me try and do this. Okay, I'm sorry, I need to move this out of the way. Okay. See. Okay, so now you should be able to kind of answer your questions on the website. If you want to do that, let's see. Okay, so we have 7 answers, and they all answer delayed sleep phase syndrome disorder. Okay, well, we have 50-50. So we have 50% answered C, delayed sleep phase syndrome disorder, and 50% answered behaviorally induced insufficient sleep syndrome. Okay, so we will talk about both of those, C and D. So, okay, all right. So delayed sleep-wake phase disorder. What is delayed sleep-wake disorder? It is a circadian rhythm disorder. And I chose to talk about delayed sleep-wake phase disorder in this presentation because it's very common. 7 to 16% of adolescents have delayed sleep-wake phase disorder. That's a huge number. Patients usually describe themselves as night owls. They have inability to fall asleep at the desired, sorry, this is inability to fall asleep at the desired time, and this could be mistaken for insomnia. So you have a teenager, they come for their 12-year checkup, 14 years checkup, And then you go through the sleep screening. They tell you when we go to bed at night, we cannot fall asleep. We stay in the bed 3 hours from 9 to 12, we cannot fall asleep. And then we have to wake up at 7 a.m. to go to school, and we are very sleepy during the day. It's not insomnia, okay? Because on weekends and on vacations, they can sleep from 12 midnight all the way till 12 noon the next day. So what they have a circadian rhythm issue. And they have inability to wake up at the desired time, which is 7 a.m. for school. And they have excessive daytime sleep, especially in the early time of the day. So they will tell you during the first periods, first, second, third periods in class, we're sleepy. We can fall asleep in class anytime early in the morning. Generally, no sleep problems if allowed to maintain their desired sleep schedule. So on spring break and summer break, the kid sleeps from 1 to 2 a.m. They wake up at 12 noon and they're happy, they're not sleepy, they have no problems. Problems only start when they start school and they have to wake up at 7 a.m. The main problem with this is because they become sleep deficient, because during school, they have to wake up at 7 and they couldn't fall asleep before 12 or 1 a.m. because of their circadian problem. So they develop sleep deficiency, so they become sleep deprived. And this can predispose them to severe problems with mood disorders, anxiety, depression, behavioral problem, all of that. And it's all because they have circadian rhythm problem. They don't have insomnia, they don't have psychiatric problems, they don't have ADHD, they have circadian rhythm disorder. And this is very common. It's 7 to 16% of adolescents. So question 2, the answer is delayed sleep phase syndrome disorder. Why it is not behaviorally induced insufficiency syndrome? Because the patient stays in bed from 9 p.m. till 12 doing nothing. So she's not like using her phone or texting someone or on her laptop. She's just doing nothing. She's trying to sleep and she can't. So she's giving herself opportunity to fall asleep, but she can't. So this is one of the circadian rhythm disorder. This is common and it's kind of tricky to treat. So thank you. So this is a common disorder and it's kind of tricky to treat. It takes a while, but most of the kids you can usually reach a compromise. In the United States, we used to give them letters for school to allow them to sleep 1 or 2 hours extra in the morning and attend school a bit late. There are some states in the United States where they actually delay school time for high school. So the rest of the school, they start at 8 a.m., elementary and middle. High school start at 9 a.m. So they give them 1 or 2 hours extra to sleep because it's very common that they have delayed sleep phase syndrome disorder. Okay, question number 3. A 9-year-old girl reports seeing a ghost in her bedroom at night. Her teachers report she falls asleep in class all of a sudden. Her parents mentioned that she sometimes collapses while walking or watching TV. She falls down sometimes. Patients also mentioned she's been feeling very sleepy during the day for the past few months. Frequent waking up at night, being paralyzed. So she wakes up at night and she says, I cannot move. She feels paralyzed for a few minutes. She has gained significant weight over the past few months. The next step in management of this child is to refer to a neurologist, do an MRI, do an LP, refer to a sleep specialist, or refer to a psychiatrist. And let me try to, okay. So I will activate this question now so you can answer on, sorry? Someone said narcolepsy, okay. We have, how many answers? Let me see. So what do you do? So far, no answers. One, we have, how many answers now? So far, we have 7 answers. So, okay, so 75% mentioned refer to sleep specialist. 25% of people who answered said, okay, now it's changing. Now it's 80% refer to sleep specialist. This is like the stock market. So refer to sleep specialist, 83%, obtain brain MRI, 16%. All right, good, good. So stopping the poll, let's go back to the presentation. So let us talk about this presentation. This is very important because those patients, it's very rare. This condition is rare, narcolepsy is rare. You rarely see it in the general pediatrician's office. But unfortunately, those patients, they get referred and they get a lot of procedures done and no one really figures out until, you know, a long time has passed. Even in the United States, it's the same. They usually get missed. and they sometimes go to psychiatry and they get treated for depression. So let's talk about narcolepsy type 1 and type 2. So that the main symptom of narcolepsy is excessive daytime sleepiness, usually during passive activities. Sleep attacks, patients just fall asleep all of a sudden. This is why sometimes it's confused for having seizure disorder or cardiac conduction disorder. Sleep drunkenness or being very, having sleep inertia. So if you wake them up, it takes them a while to pick up. Cataplexy, and what is meant by cataplexy is if the patient goes through a strong emotion, like they laugh, or they get upset, or they get suddenly anxious, but usually it's laughing, they will fall down, they will lose tone, they will completely fall down, or their neck will droop, or if they're holding something, they will drop it. And they will remain conscious. They will not lose consciousness, but they will have no tone for a few minutes. And they will continue to be able to breathe. So this is cataplexy. And cataplexy defines narcolepsy type 1. Again, patients describe cataplexy. Oh, is this seizure? Is this heart problem? Is this, psychiatric disorder? No, it's narcolepsy. If it occurs in the setting of a strong emotional trigger, then it's just cataplexy. Sleep paralysis, patients have sleep paralysis, which means they wake up in the middle of the night, they tell you, I wake up, I open my eyes, I cannot move for like 1 or 2 minutes, I'm like paralyzed. This happens in narcolepsy. It happens in also normal individuals, but in narcolepsy it happens way more common. Hypnagogic and hypnopompic hallucinations, people with narcolepsy will usually describe to you that when they are about to fall asleep, the dream actually starts when they are still awake. So they are awake, they're waiting to fall asleep, they're looking around, and they start seeing the dream happening like they're watching TV or watching a movie. And this gets confused with hallucinations, psychosis, schizophrenia, but it's not, it's actually narcolepsy. They have short sleep latency, and they also have fragmented sleep. So patients will tell you, the moment I hit the pillow, I fall asleep. This is also can be narcolepsy. But again, keep in mind this constellation of symptoms. Not all patients need to have all symptoms, but if you come across this odd presentation, keep in mind narcolepsy. And there's also weight gain. On the onset of the disease, the first few months, patients gain weight, they have behavioral changes and cautious puberty. So it could be somewhat confusing. It's a lifelong illness. It's believed to be caused by reduced secretion and activity of hypocretin in the CNS. Treatment is complicated. It needs a lot of education, a lot of behavioral changes, a lot of teaching for patient and family and teachers also. You can use stimulants such as modafinil, modafinil, methylphenidate, sodium exubate. Use that in the United States. It's a very, very highly regulated drug. I don't think it's going to be getting out of the US anytime soon, but it's really good. For cataplexy, we sometimes use SSRIs, especially long-acting SSRIs are effective for cataplexy. So let's talk a little bit about excessive daytime sleepiness, definition and presentation. It's very important because sleep deprivation and excessive daytime sleepiness is a pandemic. It's the other pandemic. It's been going on for several years. People are not sleeping enough, adults and pediatrics. And it's not getting any better. And it's actually associated with a lot of health problems. So what is excessive daytime sleepiness? Subjective sense of sleepiness or increased tendency to fall asleep at times or situations when the individual would be expected to be awake and alert. It is not the same as having fatigue or brain fog. Fatigue is being tired, but it doesn't necessarily include being able to fall asleep or falling asleep in places or times when you're not supposed to fall asleep. But it may coexist with fatigue. It may coexist also with brain fog. You have to take into consideration age and context. So, for example, kids less than 3 years of age, you put them in a car, it's normal for them to fall asleep within 5 minutes. A 6-year-old is not expected to fall asleep within a 5-minute car ride. If a 6-year-old falls asleep, within 5 minutes of being in a car, then they have a problem with their sleep-wake cycle regulation. They have excessive daytime sleepiness. Also, the presentation. It's very important to keep in mind that kids, preteen kids, elementary, middle school kids, if they're not getting enough sleep, if they're sleep deprived, or they have problem with their sleep, or their sleep quality is poor because of sleep apnea, it will usually not present as sleepiness. It will usually present with hyperactivity. So if you have a kid in clinic who's hyperactive, the mom is saying he's hyperactive, you have to ask about his sleep. Is this kid getting enough sleep? How is their quality of sleep? Do they wake up a lot at night? Do they have parasomnia, night terrors? Do they snore? Do they gasp? Do they mouth breathe? Because that might be the cause of the hyperactivity, is that they're not getting enough sleep. And then other signs of excessive daytime sleepiness, patient tells you I need a lot of sleep, like a teenager who needs 14 hours. Then that's not normal. So yes, excessive daytime sleepiness in prepubertal children can present with restlessness, hyperactivity, emotional lability, aggression, behavioral problem, ADHD-like behavior, and this is all due to a sleep problem, not necessarily ADHD, although many of them do have ADHD and they don't have a sleep problem, but you have to go through the sleep screening and make sure that this hyperactive kid, his or her hyperactivity is not due to a sleep deprivation. For school-age kids, it's very unusual for them to be sleepy during the day. So school-age kids, they're usually very alert during the day. If you have a kid who's school-age, preteen, elementary, who's sleepy during the day, that's very unusual. And you have to dig into why that's happening. There's usually a pathology underneath it, or a behavioral problem, or a house problem, or a social problem that they're getting enough sleep. And you have to distinguish between behavioral induced insufficient sleep syndrome and pathologic sleepiness. So statistics, it's a major global health concern, excessive daytime sleepiness. 10 to 20 prepubertal children and 16 to 47% of adolescents suffer from excessive daytime sleepiness at one point. Excessive daytime sleepiness in children and adolescents is underreported by parents and by physicians. What are the complications of excessive daytime sleepiness and not getting enough good quality sleep? We talked about the behavioral problems, neurocognitive impairments, declining academic performance. So they can actually may present to you in clinic because they have a problem with their behavior. Their school grades are declining, increased risk for injuries, risk-taking behavior, alcohol in teenagers. Those all may be presenting, and the main problem might be a sleep problem. Long-term increase in risk for diabetes type 2, cardiovascular dysfunction, obesity. And so what are the causes for having excessive daytime sleepiness? You have mainly 4 causes. Either the patient is not sleeping enough because they are not giving themselves enough opportunity to sleep because they stay up later, they're on social media, or they have a lot of homework, or they have a lot of extracurricular activities, so they don't get the amount of sleep they need at every night, or they have a primary insomnia, something primary medically wrong that is making it not possible for them to get sleep, or they could be having disturbed sleep, a medical problem, eczema, GERD, parasomnia, obstructive sleep apnea, something that's, although they sleep for 9 or 10 hours a night, but their sleep quality is poor. So they're either not getting enough sleep, or their sleep quality is poor, or they have a circadian misalignment, like the case we discussed, delayed sleep phase disorder, or they have a pathologic increase for sleep, like patients that post-head trauma, some medications, especially analgesic medications, or they have a mood disorder, depression, narcolepsy, something like that. So causes of excessive daytime sleepiness are many, but you have to think in terms of, especially not getting enough sleep. Is he getting enough sleep, but the sleep is poor? Is the patient having circadian misalignment, or there is some other pathology going on that leads to increased need for sleep? Quick point about behaviorally induced insufficient sleep syndrome. So this is supposed to be a subcomponent. Use of electronic devices at bedtime is associated with reduced nocturnal sleep and increased daytime sleepiness. Almost all adolescents use electronic devices at bedtime. In the US, 75% of 12th graders sleep less than 8 hours a night. So they sleep less than what's recommended. And this is why we have about 45 to 75% of high school kids in the US having excessive daytime sleepiness. A quick note about a term called social jet lag, and this happens with teenagers, it happens with adults. So you have a kid who sleeps enough hours. Let's say they sleep every night 9 hours. But you ask them about their schedule, and they will tell you that, okay, during the weekdays, I go to bed at 9 p.m. and I wake up at 7 a.m. Okay, good, 10 hours. During weekends, I fall asleep at 2 a.m. and I wake up at 12 noon. So he's getting 10 hours or she's getting 10 hours every night, but they are shifting their biologic clock by 4 hours between weekdays and weekends. And this creates something called social jet lag. And social jet lag is associated with poor outcome when it comes to mental health, cognition, and risk for disorders such as diabetes and hypertension. And the patients will feel tired because they're shifting their clock 4 hours every few days, and that's not healthy. Okay, so question 9, question 3, the answer is D, refer to sleep specialist. So our last question of the day, a 3-year-old girl with Down syndrome was evaluated for snoring. Her parents endorsed snoring on breathing to sleep. Parents report that her preferred sleep position was on her side, propped up on 3 pillows with the neck hyperextended. There's no gasping, cyanosis, or witnessed apnea. Physical exam, normal vital signs, down facies, mouth breathing, loss of total, plus 3 tonsils. The most appropriate next step, refer to an ENT, intranasal steroids, reassurance, follow up in 3 months, or number B, refer for a sleep study. Let me see if I can get this open all. Okay, so you can answer this question now. So we have referred to an ENT specialist. Let's see. I need to move something up. Okay, so we have how many answers? We have 6 answers still now, 7, 8 answers. Okay, still, okay, we have, so someone answered something, so we have 3 different answers now so far. Okay, so so far 50% answered refer to ENT specialist, 30% answered refer to sleep study, and 16% mentioned intranasal steroid spray. So these are the, we'll talk about this and we'll present the answer in a second. So OSA in patients with Down syndrome. So Down syndrome is a very common genetic disorder. Of course, you see a lot of Down syndrome, but OSA is very common in Down syndrome. So patients with Down syndrome, 50% have obstructive sleep apnea. 50% of Down syndrome patients have obstructive sleep apnea because of small, crowded upper jaw. They have mucoid hyperplasia. They have hypotonia. They have large tongue. Adenotonsillectomy is usually beneficial in children, but in kids with Down syndrome, there is a high risk of persistence after adenotonsillectomy. So you need to double check after adenotonsillectomy if their sleep apnea went away or is still there. Recognition and treatment of other comorbidities such as rhinitis, asthma, dysphagia, GERD, or obesity or hypothyroidism is important in managing sleep apnea in patients with Down syndrome. All caregivers with children with Down syndrome should have high index of suspicion for obstructive sleep apnea. So, especially in patients with Down syndrome, they come to your clinic, for a regular visit or any type of visit. You should inquire about how they sleep. Do they snore? Do they gasp? Do they mouth breathe? Do they sleep with their neck extended? How's their behavior during the day? Kids with Down syndrome sometimes they're usually very nice and very kind of quiet kids. But if you see a kid with Down syndrome who's hyperactive, then you have to kind of question: is this kid sleeping well, or is this kid having obstructive sleep apnea? And the American Academy of Pediatrics guidelines recommend that every child with Down syndrome should have a sleep study before the age of 4, regardless of symptoms. So they all should get a sleep study by the age of 4 or earlier of clinically indicated. So talking about Down syndrome, so some other genetic syndromes with increased risk of sleep disorder breathing. This is a list of kind of common syndromes that you can see in general pediatric clinic and other subspecialties. In which we encounter obstructive sleep apnea somewhat more common, and this is important to screen those kids for sleep issues. Generally speaking, symptoms and signs of obstructive sleep apnea, as you all know, frequent snoring, labored breathing, gasp snoring, sleep enuresis. So this is important. Nocturnal enuresis could actually be the presenting symptom of sleep apnea. So if you have a kid who's 5, 6, 7 years of age, especially if it's secondary nocturnal enuresis, then you have to ask questions about: is this kid snoring? Are they gasping? Do they wake up at night? Do they wake up with a dry throat? Because secondary nocturnal enuresis could be due to obstructive sleep apnea. And then when you examine them, you look to see if they have large tonsils. Do they need a lateral neck X-ray for adenoids? Sleeping in the seated position with the neck hyperextended, cyanosis, that's rare. Headaches, early morning headaches could be an important symptom of sleep apnea, daytime sleepiness, ADHD-like behavior, learning problems, cognitive problems. Physical exam, being underweight or overweight, tonsillar hypertrophy, adenoid atrophy, microventricular tachycardia, high arch palate, failure to thrive, hypertension, they could all be symptoms, signs of obstructive sleep apnea. All right, so the answer to this question is number D, referral for a sleep study. This is according to the American Academy of Sleep Medicine and American Academy of Pediatrics. So this kid is 3 years of age. So in a 3-year-old, the complications for adenoidectomy and tonsillectomy are a little bit higher in kids who are 3 years and under. So it is always a good practice to make sure or confirm they have obstructive sleep apnea before sending them for surgery. Because if they don't have obstructive sleep apnea based on a sleep study, then they won't need the surgery. Number two, it's important to do the sleep study because if they have severe obstructive sleep apnea, then the ENT surgeon should know that. Because patients with severe obstructive sleep apnea, they have tonsillectomy, adenoidectomy. Within the first 24 to 48 hours for surgery, they are highly predisposed to develop a syndrome of pulmonary edema. So the ENT surgeon should know that this kid is a kid with severe sleep apnea based on the sleep study. So after they get their tonsils and adenoids out, they don't send them home on the same day. They need to observe them in the hospital for 24 to 48 hours for development of pulmonary edema. The third reason why you need to do a sleep study is because history is unreliable in diagnosing sleep apnea. History is excellent in suspecting whether the patient needs a sleep study or suspecting the patient has sleep apnea, but you cannot really diagnose sleep apnea based on history. So for all those reasons, it's good to refer those patients for a sleep study. If you're talking about a child that doesn't have Down syndrome, a normal child who's 12 years of age, who's snoring gas mask, please have large tonsils, adenoids, then you can probably send them to the ENT specialist to get their tonsils and adenoids out right away. Or you can send them for a sleep study. But a 3-year-old with Down syndrome, then it's much preferable to send them for a sleep study. I would not use intranasal steroids because intranasal steroids in sleep apnea, they only work for mild sleep apnea. Moderate and severe sleep apnea, they don't work. And we don't know the degree or severity of this kid's sleep apnea. So intranasal steroids may or may not work. And it's risky to put on steroids and then, you don't know what's going on. All right. Okay, thank you very much. Is there any questions?
Thank you, Coach. I personally enjoyed the lecture so much lovely information. You guys have any questions?
Hi, Dr. Shamit, for a nice presentation. Thank you. Do humans we have any circadian rhythm saying that you should go to sleep at this time?
Come again, sorry?
Do we have any specific time to go to sleep so that we can have activity?
Scientifically speaking, there's really no specific time for every individual. Delayed sleep-wake phase disorder, advanced sleep-wake sleep phase disorder only become a problem when the patient's circadian rhythm interferes with their social life. So a lot of those patients with delayed sleep phase, when they graduate, like when they go to college, they take lectures that are late. So they start their day at 12 noon, and they have no problem. They start their day at 12 noon, they finish their lectures 5, 6, and then they go home, they fall asleep at 2 or 3 a.m., and they're completely fine. And they don't have long-term problems. Even when they work, they gravitate for jobs that are in the B shift or C shift, because they're totally fine working like that. Same like adults with advanced sleep phase syndrome. They gravitate for jobs that start early. So they are very happy starting work at 4 a.m. because they fall asleep at 6 p.m. Advanced sleep phase. They start work at 4 a.m., they finish at 12 noon, they're fine. The problem happens when there's a clash between the social obligations and the circadian rhythm. So to answer your question, there's no really set time to fall asleep. As long as it's the same time to fall asleep, the same time waking up, and you get enough amount of sleep in terms of hours you need per day. And the other point is kids under 3 or 4 years of age, they also need to get a nap. So kids by the age of 3 to 4, they still need to get a nap.
Okay. No more questions? I'm glad Dr. Khalid is not here. So I think thank you very much, Dr. Isham. And I think we will go now for the dinner, Dr. Bassel. You have a question? One more lecture? Oh, sorry guys, I think I have the
Hello, my name is Karina Venter. I'm an allergy specialist dietitian from Denver, Colorado. And today I will be discussing food allergy prevention in 2021. I wonder if somebody in the chat could just give me an indication about whether you can hear me. Thank you. So I've had confirmation that you can hear me, and so I will go ahead. Okay, so I would like to thank the organizers for inviting me to present here today, particularly Dr. David Cremesini, who I've worked with for a long time in the United Kingdom. And so the talk today, we will be discussing, if I just show you my overview slide, the change in food allergy prevention guidelines, where we are now with the use of hypoallergenic formulas for the prevention of food allergy, food allergen introduction, the practical way of doing it, and then briefly just look at overall nutrition and the importance of overall nutrition in allergy prevention. So changes in the guidelines. As you can see from the slide, we started in about 1998, so these aren't exact dates, it's just to give you a timeline, with both the United Kingdom and the Americans saying that we don't want babies to eat peanut at least up to 3 years of age. We'd like to withhold the other allergens, particularly from the United States. And we also want pregnant and breastfeeding women to avoid eating peanut, particularly if they're from families where there is a risk of allergic outcomes. Then around 2000, people started to go into the gray area where they were saying, well, they're not really sure what we should be doing now. We're not at the point where we're really going to say, give peanuts and allergens to babies and start eating peanuts in pregnancy. But we're just saying we don't really know what to do, and perhaps there's no reason to avoid these foods. And then we had the publication of the LEAP and the EAT study, which I'm sure you're all very aware of. LEAP study is the early introduction of peanuts, and EAT study was the early introduction of 6 different allergens. And when these studies were published, we really saw a U-turn internationally in introduction of allergens, particularly peanut, in early infancy. And so the ASCIA guidelines from Australia was the first guidelines to say peanuts should be introduced in all infants' diets in the first year of life. And that was followed by the American guidelines. I was on this panel where we said perhaps in the high-risk infant, so if the infant has got peanut egg allergy or eczema, we want to introduce peanut by around 4 months. All other infants should get peanut at least within the first year of life. And then we had the UK advice, again, sort of like mimicking this NIAID guideline, saying our high-risk baby is the baby with eczema and or an egg allergy. We really have a race against time because we want to get the allergens into the baby's stomach before it actually penetrates via the eczema skin. And so really for these babies, 4 months, any other babies, we really want to get peanut into the diet as part of a normal healthy infant diet in the first year of life. And we also had the American Academy guidelines then saying peanut really has been shown introduction in the first year of life, probably around 4 to 6 months of age, has been shown to prevent peanut allergy. So you can really see how the guidelines made a big U-turn from let's avoid peanut to now saying we really want to get peanut into the babies with eczema diets around 4 to 6 months if they're ready to eat, in all other infants at least within the first year of life. But in terms of the maternal diet during pregnancy and lactation, we're still not much clearer than just being able to say there's no need to avoid, but we're not at the point where we are saying we actively have to introduce peanut and all other allergens into the mom's diet. Then something that I know Dr. Kramasini asked me a lot about, and it really is a big question mark in terms of allergy prevention, is the use of hypoallergenic formulas in terms of partially and extensively hydrolyzed formulas for allergy prevention. And this is a paper that I would like you to read from John Genuit and Bob Boyle, recently published in Pediatric Allergy and Immunology. And it really takes you through the very sad story of the data we have on hydrolyzed formulas and allergy prevention, saying that in 1989, we had the first study, a fraudulent trial published by Chandra, but at the time, we didn't know that it was fraudulent until 2006. So the guidelines sort of like between 1989 to 2006 hovered towards saying, you know, we suggest the use of partially and extensively hydrolyzed formulas for allergy prevention. And we went as far as the EC directive in Europe recommending partially hydrolyzed formula for prevention, and also still in 2011, the Food and Drug Administration in the USA allowed the partially hydrolyzed formula to put a qualified health claim on to say that the milk has been shown to prevent eczema, not food allergy, eczema. But what a qualified health claim actually means is the FDA may not necessarily agree with you, and they may not actually think your data is good enough, but they're not going to fight you. So we have to realize that the qualified health claim doesn't mean the FDA thinks that it's definitely avoiding eczema. But anyway, ever since then, we had the LOW trial from Australia published to show that extensively hydrolyzed and partially hydrolyzed formulas, particularly partially hydrolyzed formulas in the LOW trial, had no effect on eczema prevention. We had the PATCH trial showing the same. We then had the updated Cochrane review, including the LOW data from Australia. We also had the systematic review published by the Food Standards Agency. And then we had retraction of the PATCH trial. So yeah, as you can see, you know, it has been published data, fraudulent data, health claims allowed, new data published, data retracted, and so things go. So at this point in time, and also, even though we can say here that some studies showed no effect, it just wasn't statistically significant. When you look just at the raw data of using hydrolyzed formula, either extensive or partially hydrolyzed formula compared to cow's milk formula, there's always less allergy in the hydrolyzed formula groups. It may just not be statistically significant. But anyway, based on this very sad story and confusing picture, all the allergy guidelines in the world basically now recommend against or not using hydrolyzed formula for allergy prevention. And so here you can see the Australian guidelines saying hydrolyzed formulas are not recommended. European guidelines, there's no recommendation for or against. I was on the European guideline committee as well. And so we're very safe saying we can't recommend for or against it. The AAP guidelines saying there's a lack of evidence that hydrolyzed formula prevents allergic disease. The US American Academy College and Canadian guidelines, I was on that panel as well. The lead authors at the front and end of the paper, Dr. Fleischer and Dr. Greenhood, are people that's much more direct in how they publish. And so they actually said, do not use any hydrolyzed formula for prevention. And the BSOCI current guidelines made no statement. So again, you can see that really the guidelines are going from don't use it till we really don't know and back to we really do not recommend it. But the practical question is what do we say to mothers that can't breastfeed or their milk hasn't come in by day 3? And so the next 2 studies I'm going to show you has not been included in any of these guidelines, but I think it is worth taking a note of them. And so the very first study looked at, it was a study by Yuri Sharma, and they looked particularly at this group where we can't breastfeed for the first 3 days, or mom hasn't got adequate amount of breast milk. And so they compared a group that was breastfeeding with cow's milk and infant formula added to the baby's diet, at least more than 5 ml a day, versus a group that was breastfeeding, but they actually gave the babies an amino acid or elemental formula as a supplement or a top-up in the first 3 days. Then they stopped. So the intervention was only 3 days long. But fascinating when we actually look at the outcomes by 2 years, the babies that had the cow's milk formula added to the breast milk had 6.6% cow's milk allergy, whereas the group that in those first 3 days had the elemental formula added to the breast milk had only 0.7%. And so the question at this point is, in the lack of any guidance, whether if a mom really needs to get a supplement feed, because at the end of the day, you know, the babies need to grow and get calories, whether perhaps in that, just for that initial period, an amino acid based formula may be a suitable option. If we then go to the next one, which I actually think is just as interesting. So these babies were fed for the first month, mainly breastfeeding. And then after 1 month, the breastfed group continued, but if they needed a supplement, they gave soy formula. And then the cow's milk group, they continued to breastfeed, but if they needed a supplement, they were asked to give the babies a cow's milk formula more than 10 ml a day. Here you can actually see that the average consumption of cow's milk from 1 month onwards was about 3.5 fluid ounces or 100 ml a day. And then they continued basically with the cow's milk intake, and from 3 months the soy formula group was also allowed to then introduce cow's milk. And fascinating when you look at this group where they started to introduce cow's milk at about 1 month of age as a formula, and they continued up to 6 months of age. When you looked at the cow's milk allergy outcomes at 6 months, the ingestion group, so the group that had the cow's milk in small amounts from 1 month onwards, had much less allergy, 0.8% versus 0.6% in the group where it was started later. And so, you know, there is this question about whether we can see from the first few days of life, giving cow's milk and stopping is not a good idea. We see that when we start introducing it as a supplement alongside breast milk and continue, that it actually leads to less allergy. The other important thing that we need to look at, because that of course was the first thing I looked at when I read this paper, was did the mothers who started the cow's milk formula, the little bits added, stop breastfeeding sooner? And actually the group who started the cow's milk had similar rates than the other group. So again, it didn't seem that as if small amounts of cow's milk given alongside breastfeeding from 1 month of age negatively affected breastfeeding. So I think what we can take from the last 2 studies is we want to breastfeed exclusively if we can. But if I think for any reason at some point cow's milk formula is given to the mom as a supplement feed for the baby, then we need to continue. I think we've learned also from the peanut studies, the immune system doesn't like it when we chop and change our minds. So once we start feeding cow's milk, we need to keep going. Small amounts seem to be enough. It doesn't mean that just because you've given 10 mils or 2 teaspoons of cow's milk formula that it's the end of the world and now you have to stop breastfeeding. You can continue with those small amounts alongside breastfeeding. But like I say, this is my interpretation of the guidelines, working with many desperate moms who needed some supplement in the first few days or the first week of life. The guidelines haven't actually addressed this particular issue. So that's sort of like the change in guidelines, then the change in formula. The next 5 or 6 slides are very practical slides, which I'm very happy to provide if you want to use it. But we have actually written a paper, Brian Schroer, Marian Gruch, Doug Mack, and myself, where all this information is condensed in a very handy handout in the supplement of the paper. So if you want to look at that paper, then for peanut, there's also easy to print off handouts on the web, which I've written alongside the NIAID guidelines group. So if we're going to start peanut when the baby is ready to feed, how much, how long, how often, we say about 1 to 2 teaspoons of peanut butter. If you have peanut butter powder in your country, then you can use that too. 2 to 3 times a week as tolerated. And once you start, you have to continue. I think I'm going to say this a few times in the talk today, so I hope I'm not going to bore you. Introduce, keep going. You know what? The amount is probably less important than the fact that we keep going. When we look at the egg, it's about 1/3 the egg, 2 times a week. It has to be well cooked or boiled initially. So at least for the first month or 2, we want a really well-boiled egg, which you can mash down with breast milk or with infant formula. It works much better in a blender, I can tell you that. And once you've got a nice little blend of this boiled egg, you can mix it in with the baby cereal or fruit puree or whatever you use to feed the baby with. But very important, we talk about a well-cooked egg, 10 to 15 minutes of boiling for the first 1 to 2 months, and then we can go on to things such as omelets or perhaps a soft-boiled egg. And again, dose is probably less important than the frequency. Keep it in the diet often and keep going. Sometimes babies get sick. If they don't want to eat for a week, it's not the end of the world, but once they're back on food, let's do that again. Then introducing other allergens. So here, you know, you've got an ounce of grains every day. Just comes from healthy eating guidance. We don't have allergy prevention guidelines telling us how much wheat, but daily intake of wheat as the baby would eat it. Nuts and seeds, we don't know how much of the other nuts and we don't know how much seeds, but the healthy eating guidelines say about 3 teaspoons at least once a week, but I will show you a recipe now. And then milk is an easy one. The guidelines say about 2 to 4 fluid ounces a day. So if they're not on infant formula, that would be a yogurt. And then for fish, we say 2 to 3 times a day, 1 ounce per serving, not much more because of the mercury concern. Nuts, I'm going to show you a recipe now for twice a week. And tofu, we say once a week, about 4 tablespoons, or you can split it up twice a week into 2 tablespoons. But it's important that once you start giving these allergens, keep it in. And so this is just the tree nut butter recipe we've published in this paper, which you can look at. It makes it very easy. You stick all the tree nuts and peanuts into a liquidizer or a blender, blend it together with a little bit of oil, keep it in the fridge, and you can give just 2 to 3 tablespoons, perhaps 2 tablespoons would maybe easier, twice or 3 times a week, just to keep the nuts in and keep the frequency going. Then in terms of overall nutrition, I just want to go back to that one. It's just sort of like flick past. So here you can see all the tree nuts and the peanut And we also indicate the gram of protein, and then also the amount per nuts. But like I said, it's about 2 tablespoons a week would be sufficient. So then looking at overall nutrition, so now we talked about the formulas, we talked about getting the allergens in and keeping them in once the baby is ready to eat. And then I will just look at overall nutrition. So let's look at diet diversity. Somebody just asked me about, is fruit banned from babies' diets? And I'm going to talk about that now. So some of you may follow me on Twitter. This is a very old tweet where I ask all these allergists and dietitians who follow me on Twitter in 2018, what do they think diet diversity mean? Normally, I get about 50 votes or more. In this case, only 5 people voted, which is an indication they really didn't know the answer. And so I got an EACI task force together with international experts in immunology, pediatrics, all over the world to define diet diversity. I'll show you the paper in a minute. So diet diversity is really just frequency and the number of foods really you give a baby. That could be number of fruit and vegetables. And no, it is not banned from a baby's diet. It's a very important part of a baby's diet. You can look at number of allergens given. You can look at number of food groups given. But it's basically just counting the variety in a baby's diet. And then we also looked at diet quality, and that really gives you more of an idea of how much fat, how much sugar, how much sodium, how much protein and carbohydrate is in a baby's diet. And normally to look at diet quality, we would use diet indices such as the Healthy Eating Index and diet patterns as well, such as the Mediterranean diet, which I'm going to take you through now, because I do want to say that allergy prevention don't just stop and start with which formula we choose and how many allergens we give and how often we give it. It really is about the overall diet because there's huge immunomodulatory potential in the food that we eat. And so this is the paper that I got together, if you want to look it up, with this group of international experts. And first looking at diet diversity in infancy. When we did the systematic review, there was only 1 paper published, and this is the one from Caroline Ruday in 2014, looking at diet diversity. So the more foods given in early life versus food allergy outcomes at 6 years of age. And she clearly showed that if we can increase the variety in a baby's diet, fruit, vegetables, grain, meat products, if you're not vegetarian, otherwise then things more like soy and legumes, we can significantly reduce particularly food allergy in later childhood. And here are the 2 beautiful graphs that she published. We looked at food diversity score versus food allergy. And here you can see as food diversity increased, so did food allergy come down. And the same was true for asthma. And you know, ever since 2014, I loved this paper and I so wanted to publish my own one. And I'll show you my data now in a minute. And so following from this EACI systematic review, I looked at my data on the Isle of Wight. Now I'm based in Colorado, of course, but at the, I did my PhD and postdoctorate on the Isle of Wight in Southampton in the United Kingdom. And I defined diet diversity any way I could. I looked at number of foods eaten using the WHO definition, food groups really, number of foods given, number of food allergens given, and then again getting back to the fruit question, number of fruit and vegetables introduced. And you know, the message was consistent. As you increase variety, food allergy prevalence come down. It doesn't matter whether you count food groups or fruit and vegetables or food allergens or just each and every food given. The more variety, less food allergy. And so here are my graphs similar to Caroline Ruday's, and fascinating, the number of foods given by 6 months. So these babies were weaned from a young age when they were ready to eat. It was small portions, but rather than just giving baby rice or baby corn or just applesauce or just mashed banana for the first week or 2, these mothers actually gave small portions, 1 to 2 teaspoons at a time, of apple juice, banana, baby rice, baby corn. And as the number of foods increased, so did the odds of having food allergy come down. And I'll show you on the next slide, for each additional food given, the odds came down with about 11%. So really every food counts. Then we looked at the number of allergenic foods given by 12 months. And once again, as the number of food allergens introduced over the first year of life, so this is not 6 months, so did the odds of having food allergy come down. And for each additional allergen we gave the baby, the odds came down with 33%. So I always say to moms, every allergen counts. Make my nut butter, feed it to the babies, because in every tablespoon you give twice a week, you've got 9 different allergens you're giving your baby. So it's really important to try and get diet diversity and allergen diversity as best as we can. So here you can see just a summary that for each additional food score, we brought the odds down by 11%, and for each additional allergen, the odds came down by 33%. We also looked at whether moms with babies with eczema were less likely to introduce foods, and they weren't in the study. I'm not saying that's true for all studies, but again, the data I showed you also applies to kids with eczema. We shouldn't be scared to feed these babies. And the reason I have that picture is, if you feed a baby with eczema fruit puree like that goes everywhere, they're gonna get hives and they're gonna have flushy cheeks, and mom is gonna get totally freaked out. And so for these babies, we say, do wean, but put a little bit of Vaseline around the face and on the cheeks, so that the baby, you know, doesn't get the hives and the flare, which seems to go away anyway within 10 to 15 minutes. So that was diet diversity. We don't have data on diet diversity in pregnancy, but in early life, message is clear. Don't wait 3 to 5 days between every new food. Just open up the diet and get the babies eating, you know, just let them eat. Then the last few minutes, I just want to talk about the pregnancy diet. We don't know what breastfeeding women should eat. I'm not going to waste your time. We have no data. But if a pregnant mom asks you questions about healthy eating, we have many different ways of defining healthy eating, which I don't want to go through in detail, but bottom line is we focus a lot on salt and sugar and fiber and fat. But when you look at healthy eating indices in pregnancy versus allergy outcome in the infant, not associated. So basic healthy eating or standard healthy eating as we know that, with a focus on fat, sugar and salt, doesn't actually seem to reduce allergy outcomes in the infant. That doesn't mean you don't need to eat healthy, and I'll get back to that in a minute. And then we look at inflammatory diets, you know, so we let them eat more ginger and saffron and less fried foods, and more omega-3 fatty acids. And so we thought perhaps if we get the moms on a less inflammatory diet, we can prevent allergy. And once again, very disappointing. The only positive hint we get is a less inflammatory diet associated with less asthma and less wheeze, depending really on how it was defined. So perhaps if you have a mom with asthma on a very unhealthy diet, you may want to consider putting the kid on or the mom on a less inflammatory diet. But I then analyzed my own data here in Colorado, and I thought that if the moms are on a less inflammatory diet, I'm going to see less pro-inflammatory cytokines in the cord blood and more T regulatory cytokines. I saw nothing. So putting moms on a less inflammatory diet didn't affect cord blood cytokines anyway. Then I also looked at moms on a less inflammatory diet versus asthma outcomes in the children by 4 years of age. We did include asthma and wheeze as one variable. And in the unadjusted model, we did see a significant effect as the previous study, but by the time we've adjusted it for maternal asthma, body weight in pregnancy, smoking, etc., we lost our significance. It's almost significant, but not completely. So again, you know, this is saying perhaps there is a pathway through which a less inflammatory diet may prevent wheeze and asthma, but it doesn't seem that the pathway goes via the the cytokine pathway. And I'm going to give you just a brief explanation about that. And then we looked at the Mediterranean diet score. We thought, let's put moms on Mediterranean diets. Once again, very disappointing data. Out of the 4 studies we have, only 1 study showed that, again, it was less wheeze and less atopic wheeze and less ATP, which was a whole range of skin prick tests. So really healthy eating in pregnancy, whether we define it as healthy eating, less inflammatory diet, or Mediterranean diet, at best is going to prevent some wheeze and asthma. But then just about 2 weeks ago, I've worked on this paper in my head for 20 years. I have dreamt about this paper for 20 years. And I finally managed to get all the data together and get it published. And this is an index I developed in pregnancy where we looked at all the things moms ate. And basically what we showed is a diet rich in vegetables and yogurt with less red meat, sugary cereals, low fiber cereals, because these moms all ate Uncle Ben's rice. So it was all white rice with no fiber, and drink a lot of fruit juice opposed to eating fruit. Was associated with reduction in atopic dermatitis, asthma, allergic rhinitis, wheeze, and food allergy. And so I think this is a very simple message for moms. It was published in Allergy 2 weeks ago. Get your vegetables in, get your yogurt in, and don't overdo things that's high in sugar, low in fiber, and fried, you know. And not saying you can't eat it at all, but definitely cut it and definitely put huge emphasis on vegetables and yogurt. So the data I'm not showing you today, and I know I have to finish, is that I thought that this would go via the microbiome pathway. We didn't actually saw any signal with change in maternal or infant microbiome on this diet, but there were very strong epigenetic changes, particularly the epigenetic marks associated with the filaggrin gene. So it looks like maternal diet may prevent allergy via an epigenetic pathway, and perhaps less so microbiome pathway, but you know, we're still cleaning up the microbiome data. And there's no diet indices in pregnancy. I explained to you that the mechanism may be epigenetics for pregnancy. In infancy, I just want to show you this slide, diet diversity in infancy. So the diet index in pregnancy, epigenetic pathway. Diet diversity in infancy seems to go via the microbiome pathway, because as we increase family food, increase moderate amount of protein, increase fiber intake, and don't increase fat intake in the baby's diet, we see a much more diverse microbiome. And the diverse microbiome, getting back to Caroline Reday's data, showed increased production of butyrate with more T regulatory cells by having a more diverse diet in pregnancy, and we saw less allergy outcomes. So really, there may be different mechanisms preventing allergy depending on the timing of the intervention, which is something I write a lot about as well. I don't think what works in pregnancy is necessarily going to work in infancy and vice versa. And so this was a mouthful. I've tried to cover it all for you in less than 35 minutes. The guidelines keep changing. This is the bit that I want to say. You can read the rest later on. But they all agree, let the babies eat, get the diets diverse, don't be scared of allergens, feed them. We don't know what to do with the hyperallergenic formulas at present, and we're just beginning to learn about the maternal diet in pregnancy, and we have a lot to learn about the maternal diet during lactation. And so this is just my collaborators that I would like to thank. So with that, I'm going to stop my slide share now and see if you have any questions for me. I can't hear anything, so I was able to hear the previous speaker, but at the moment there's no sound. So perhaps if you want to put something in the chat, or otherwise I will just conclude this and say thank you very much for having me.
Any questions for us? That was nice. Anybody has a question? Okay, thank you, guys. This is, I think, our last.
Thank you. Thank you.